because, I cut a lot of dealing with these activities. Now, as you know, the breast cancer phenotype, as you can see here, the majority are ER positive, HER2 positive disease, at least in the King Faisal, around 16%, and our triple negative is about 12%. I will let you know how much the tumor burden load or the mutation load that require to understand the immune system, the pressure on the immune system. And indeed, as you can see here, the Lumina A and Lumina B, including the HER2 positive disease, they have a weak pressure from the immune system, and it is almost very extremely low. The HER2 enriched and the triple negative, it is indeed the one that is strong pressure from the immune system. So when we are talking about the immunotherapy, we are thinking about the HER2 enriched, which is the hormonal receptor negative, HER2 positive, but the majority of these patients are triple negative disease. And we agree on that. Other things which is very important, maybe this is a recent publication, that the heat map of the immune checkpoint gene in breast cancer, we have 50 of them so far. And anything red, that means immunogenetic. And as you can see here, the BD1, BDL1, BDL2 are mainly in the triple negative, and there are small of this in HER2 enriched disease. The new one is OX40, and I will show you that. And then, as you can see here, the CD70, CD80, the CD1137L, and then, the CALGA4 and so on has not been translated into clinical trial, and we have difficulty to understand this. So we have 50 of them, but we are using the BD1 and BD1 and BDL1, and maybe, we are talking about the BDL2, but when we are coming to the OX40, maybe in future, we will have something for such patient. Now, as you remember, in the 2011, this is the classification of the triple negative disease, but now there is agreement, at least in 2021, that this is the gene expression profile that we are using in the majority of clinical trial, which has been established since 2015, based like immune suppress, based like immune activated and mesenchymal and luminal androgen receptor. And since then, most of the study are concentrating on this direction. And then, this is in 2021. As you can see, this is the 4. This is the upgraded pathway, as you can see from here. And this is the potential drug target. As you can see, there are a couple of them. And none of this until today has been translated to the patient benefit. And I will show you that. Now, everybody agree at this moment that, this is how we divide the immune-rich patient. For the triple negative disease, immune-rich, which is the small, increase the TELs, BDL1, enrichment in the immune response gene, immune checkpoint inhibitor, and we are going to talk about this. And this is the area that we are a little bit of our understanding. Then we have the mitogen activated protein pathway. We have the DNA repair deficiency, the PI3K18 mTOR activation, and then anti-androgen therapy, and so on. So when you are going to talk about the immunotherapy today, in March 2021, we are talking about this because all the other 3 has not so far translated to patient benefit in progression-free survival or overall survival. So always remember this slide and the direction in the future where we are going to go in the immune therapy. This is a very important for triple negative for everybody, guys, where we have a lot of molecules that it has been studied and used. Some of them, there is a minimal benefit. Others, there is no benefit. But when we are looking for the immunotherapy, which is our talk today, we have so far 13 molecules. We have 13 molecules. We have Nevo, we have Bembro, and then, we have Atizo, and we have Avilo and Duraluvimab. And then we have, this is in the clinical trial, which is the OX40, and then we have 4-IBB, and then, another molecules here. So basically, when we are talking triple-negative immune, we have 13 molecules in clinical trial who has been established so far. We will talk about it, is Bembro, and then, Atizo, and some of the others. This is the major. But when we're looking for this, all this together for the triple negative, the only one which has been shown that, there is a survival advantage in triple negative is Trobo2, which is tocilizumab. This is, which is affecting the Trobo2 protein. This is the only one which has been shown benefit in triple negative disease so far. So at the level of the immune, we have 13 molecules. Bembro and Atizo are the one that we are going to talk. This is the one that we have. Now, the triple negative disease breast tumor with identity crisis, indeed. Triple negative is shaped with high immunogenic potential, as we mentioned in previous slide. Certain checkpoint has been investigated in metastatic and early disease, and I'm going to talk about this. And the response rate to this antibody are higher when we're adding chemotherapy. I will show you that. The triple negative has more aggressive clinical course and indeed inferior survival within 5 years of diagnosis for this 15% of our practice. Despite aggressive biology, tend to be more responsive to neoadjuvant. This is which is called the triple negative paradox. Triple negative paradox that patient respond, but relapse early and die from the disease. And it is 6 times likely to have recurrence and 12 times more likely to die of metastatic disease in patient who has not been achieved PCR. And I will show you some of our practice and the result, at least at the King Faisal. Now, just for everybody, guys, is there optimal first-line chemotherapy? We will come here, and as you can see, from here that you have paclitaxel, it is about 9 months. Now, paclitaxel, it is very expensive. It is 9.2. Except people know nobody would use it today. It is about 7.6. So for you, if you don't use the immunotherapy, first line, that maybe you are using a single agent paclitaxel, very cheap, at least in the King Faisal here, 1 dose, it costs exactly 80 reals, where the nab-paclitaxel, if you are using day 1 and 8 and 15, it is about $2,000. So this is, as you can see here, just for teaching for our junior, that the paclitaxel first line, that it can be used with no harm, and do that if you don't have the potential to go for immunotherapy, and I will come to this. Other things which I am using, and Ahmed Badran, he knows that. I love to use the paclitaxel Gemzar. And in fact, my overall survival here at my patient, it is about 19 months. And here, the progression-free survival, it is about 7 to 8 months. And then, the overall survival here, at least for our patient population, exceeding 62%. So if you are using a single, use paclitaxel. If you want to use a combination, use Bacli and the Gemzar, which is day 1 and 8 every 21 days. So this is to make you relax about, the treatment of the triple negative. Now, when we are we are going to discuss the clinical trial of immune checkpoint inhibitor, advanced stage triple negative. It is very important to slide this when we are looking for the monotherapy, which nobody will use it. For metastatic triple negative, the complete response, if you are using Atizo, it is about 10%. When you are using Pembro, it is about 5%. When you are taking CR and PR, as you can see here, it is 23 and the 26. If you are exceeding one line, second line, third line, you see how much drop in the response rate. Now, just to show this, this is the whole trial that used the monotherapy. If you are looking for the response rate, it is not exceeding 10. If you are looking for the median progression-free survival, it is about around 2 months. And you are looking for the median survival, it is about 9 months. This is the Keynote 119. This is just published on March 4, 2021, showing that, as you can see here, the progression-free survival for the whole patient is about 2.1 versus 3 point. And this is, again, who is positive more than 1%, 10%, and 20%. Again, the progression-free survival is not dramatic. So the first message that I want to give you, don't spend money on monotherapy for a patient with the triple-negative disease. Now, again, here, when they are adding chemotherapy, the overall response rate, it is increasing 38 and 32, which is, in my opinion, is not helpful, given the fact the overall survival, the overall response rate in the monotherapy, either atezo or pembro, is very, very small. Now, let's look for randomized clinical trial, and I will go very fast about that. We have IMPassion, 130, IMPassion 131. Keynote, I am not going to talk about it because it is monotherapy. And then I will tell you about, 355, which is pembro plus chemo, placebo versus chemo. As you can see here, there are a good number of this. Forget about this. We are going to discuss all of this in details. Now, the other things, this is the IMPassion 130, which is very well known, that, patient who is triple-negative disease, first line, adjuvant, neoadjuvant more than 12 months, they are randomized to atezo, nab-paclitaxel. And, remember, the nab-paclitaxel in this clinical trial is 100 milligram per meter square, which is not the right dose, because nab-paclitaxel, the right dose is 125 milligram. And they continue for treatment until progression on acceptable toxicity, progression-free survival, and overall survival. Importantly, that it is tested for intention to treat. Okay, so this is when you are looking for intention to treat, guys, it is 5.5 versus 7.2 for atezo. When you are taking for the whole patient who is BDL1 positive, giving 5 versus 7.5, okay? Well, as you can see here, the difference is not that much. However, the p-value has been reported as a significant for progression-free survival, okay? And then when we're looking for the overall survival, here again, the progression-free survival, as we mentioned. So patient who is BDL negative, don't use it. BDL1 positive, we should think about it. And then here, when the overall survival, negative, useless, this is the difference between the two. But what is the unique about this? They didn't mention to us the p-value even within the new publication. Now, this is the one that just published about 2 weeks ago. The BDL1 expression, as you can see here, this is the trial. The majority, as you can see, 60%, they don't benefit because, as you can see here, the BDL is negative. For sure, it is out. We have the low one, which is less than 10%, and the high one is only 13.9% in this clinical trial, about 14. Now, when you are looking for the difference between this in progression-free survival, patient, 9.3 versus 6.1, when you are jumping here 28 and 10, which is considered to be, that is significant if you have such patient that, above 20% of the BDL1 positivity, and you trust the lab that, you give you the result. Now, one thing that I want to tell you, if you are using this medication, every 3 months, do TSH, free T4 and T3, because hypothyroidism is a significant. Don't forget the rash. It is almost about 30% of the patient, they may get a rash. Don't forget the pneumonitis, which is the considered three if you are using atezo or even pembro or any of this. So hypo, rash, pneumonitis, very small chance of adrenal insufficiency. So when we are looking for the summary, as you can see here, the overall survival boundary for statistical was not crossed in the intention to treat population, and they don't talk to us about it. As you can see here, for me, I don't know how I am going to use this nab-paclitaxel plus atezo, where it is very expensive. Now, the Impassion 131, I am not going to spend a lot of time, and again, we need to think about it. It is the same application, triple negative, first line, no prior chemotherapy. You have to somebody giving adjuvant, neoadjuvant more than 12 months, and then, atezo, but this is a paclitaxel, placebo paclitaxel. The dose of paclitaxel is right, with day 1, 8, and 15. And then this is the PD-L1 positive patient, attention to treat. I want to look for this. Liver metastasis, the number are small. Mortary, it is very small, very selected patient. I don't know how they were able to get this number of patient by this classification. Now, de novo, it is only 30%. The majority of these patients have adjuvant and neoadjuvant. As you can see here, this study is negative, 5.65 for progression-free survival. And then for the one who is BDL positive, 5.7 versus 6, again, is not significant. Overall survival is negative. And then the outcome, as you say here, was not met. So you have to think about it. Why atezolizumab, they give that, and atezo paclitaxel does not meet the primary endpoint. So there is something wrong, at least for understanding. Now the K35, the Keynote 355 studies, again the same patient population. The only thing that they are more 6 months before the first recurrence instead of 12 months for adjuvant, neoadjuvant. Pembro chemo, use nab-paclitaxel. You see here 100 milligram. This is not the right dose. Paclitaxel 90 good. Gem, it is as well as the carbo. So for this group of patients, as you can see here, the progression-free survival is 7.5 versus 5.6. But it is very interesting that the statistical significance for the p-value not tested due to hierarchy testing strategy, which is very strange. And then when you are looking for the progression-free survival for PD-L1 more than 1%, again, as here, they say that it is not significant for the p-value. Now, if it is more than 10, they don't give us the p-value, but they say it is 9.7 versus 5.6. And this is the conclusion. If you have somebody more than 10, they may benefit from using this combination. And in fact, the majority, they believe that more 20 is needed to think about this. Other things which is very important from my previous slide, they tried to use target therapy with the combination PARP inhibitor. It is useless, and these two medication has been used. And the AKT inhibitor, a lot of intention have been given to this clinical trial. However, the number are very small, and the outcome was in fact negative. I remember that the cost of this clinical trial by using this, it is about 58,000 real per cycle, which is again the same for this, about 60,000 real per cycle every 3 weeks. You are talking about, and then the overall survival, and I don't think that we are going to see them again in the triple negative disease. Now, the immune checkpoint inhibitor in early, we have 3 of them again. We have Keynote 522, we have Impassion 031, and we have the neoadjuvant trial, which is called NeoTRIPA BDL1. The size, as you can see here, this is big. this is acceptable and this is a small number, but let's do. The outcome, they are talking about the BCR rate, and so far, none of this, has been, established by the FDA approval, either in United States or Europe, or at least in the Kingdom of Saudi Arabia. I would like to mention in the metastatic disease, the Pembro and Atezo has been approved, but at the last slide, I will tell you that it is most likely to be removed. But let's complete this. Now, the Impassion 013 phase 3 Atezo neoadjuvant, as you can see here, this is a very aggressive one. You see here, the guys, they changed the dose 125, okay, Atezo and nab-paclitaxel, and then, this is nab-paclitaxel. So patient who is more than 2 centimeter, T2, okay, and also from not high risk and entry, this is most of this patient are locally advanced in nature. So they give Atezo nab, then Atezo nab and doxorubicin and cyclophosphamide, the dose we use, surgery, and then subsequent they give this and this, and they are looking for survival and follow-up. Now, as you can see here, it is very clear, guys, that the difference is 16.5 between we are giving Atezo versus non-Atezo. Again, this is the one that BDL positive, the difference, but look for the BDL negative. There is no much difference between the two, and it is about 13.3, but I consider this one is not high. Again, I'm not going to repeat the same thing, but just remember, everybody, hypothyroidism and rash and the pneumonitis. You see here the rash, it is almost about 49% they have a rash on Atezo and chemotherapy. This is the Impassion that, they say that it is significant, but we are waiting now for event-free survival, disease-free survival, overall survival, and I will tell you the story at the end of this. Now, this is the Keynote 522, which is just in Barcelona 2019, the same issue for that. It is carbopaclitaxel, and then doxy or EC cyclo, Bembro, and then the CMO, the placebo. They have a surgery, and then they continue this one for 27 weeks. The same neoadjuvant patient from T1 high risk and N1, N2. Also, they include T2 and T2 up to T4, and also N1 and N2. Now, as you can see here, the primary endpoint is not impressive too much for me, but here for the BDL positive, it is exactly like the first one, but for the BDL negative is not impressive. Now, the survival, there is a difference, 91 versus 85, but they don't give us the p-value. And the event, as you can see here, per percentage is higher in the placebo group. Now, in summary, again, it is the same issue. It is better. The difference is 13.6 in patient who is BDL positive. Other things, we don't have more than that. This is the design of the new trial. Again, you see here, nab-paclitaxel, again, 125, carbo 2, and then carbo and Atezo plus nab, the same issue. And then after the surgery, they finished this, they gave all the patient intracycline base, and the primary endpoint, again, the same thing. As you can see here, overall is not impressive, but the BDL positive, the difference is about 3%. It is very interesting. The BDL negative is it is almost the same. This is another study when they give durvalumab placebo 2 weeks. There is a window and non-window. Again, is not that much of important. Nab-paclitaxel given at 125 milligram, and then EC 9600, and so on. Now they are looking for the difference between the window and non-window, but so far we don't have that result. Now, again, in this summary that, there is a difference between two. Just to give you idea about, just without, this is our result in multi-center prospective phase 2 clinical trial neoadjuvant that, we published. And we have, for triple negative disease, we achieved, 36% in breast and axilla, and this is 73 in the axilla with only chemotherapy consisting of FIC followed by cisplatin docetaxel, and this is with or without trastuzumab, but this is mainly for triple negative. Recently in February, we published a 681, which is the largest series locally advanced in literature so far. 681 with the medium size of 7 centimeter. We published in February in Journal of Oncology. And the BCR for a patient, again, who is triple negative, it is the same, 31, 60, and 37 without any type. And here, this is a very important for our region, where the 5-year survival for the BCR is 83, which is less any other things. That means triple negative disease is a problem in our region. No PCR, 5 years, 61%, only, and we lost almost about 40% of the patient. And the characteristic of our patient, usually they relapse in less than 1 year. And this is something we need to learn about it. Now, why I'm saying this? Now, the problem with the immunotherapy, for the breast cancer, I just give you one thing about that. If you have 100 patients, you have 100 patients as a practice, and you have 15% of these patients are triple negative, all right? And you have, so the 15 patients who are of these patients are eligible for 15 patients who are eligible for the immunotherapy. If you want to apply the immunotherapy, so the only one that it is about 10%. So that 15, you have maybe 2 patients all the year, they may benefit from immunotherapy, because not all of them, they are going to this. So that means the immunotherapy for breast cancer, for triple negative or the others, is still a long road to go. Now, I did a clinical trial, big clinical trial on the durvalumab. I have very, very good experience with it, in metastatic breast cancer at the King Faisal. But so far, we didn't use Pembro or Atezo in metastatic breast cancer or a neoadjuvant setting so far. So, see here, very strict. According to this, okay, there is a meeting, and every one of you are going to meet this, and I'm going to send this information to Dr. Ahmed when it is come, because I am part of this. In April 27 and 29, the FDA Oncology Drug Advisory Committee will review the indication granted through the accelerated approval process for 3 immunotherapy. I'm talking about Pembro, Atezo, and durvalumab. There are 3. My feeling, there is a high possibility we are going to learn on the 29th or the 30th of April. There is a lot of this immunotherapy is going to be withdrawn. And by this, I would like to thank you. So if you are lucky to treat 2 patients, if you have 100 triple negative a year, you are a good medical oncologist. Thank you.
Thank you, Professor Tahir, for this excellent presentation. As usual, usually you raise a debate and then the world will follow your debate. Now the floor is open for any question from the attendees. Please send your questions on the Q&A section, and we will head it to Professor Tahir to answer.
Anyone else? Thank you, Ahmed, very much. Thank you, everybody on this board.
Thank you, Professor Tahir, for this excellent presentation. I think we don't have any questions then now.
No, there is no question, Ahmed, because there is no point for the question.
Okay, thank you, Professor Tahir. By this, I think no question received. So by this, I end this talk, Professor Tahir. And if I receive any question after the next talk, I will head it to you, sir.
Okay.
Now, actually, it is my honor to introduce my dear colleague, Dr. Mohammed Kilani. Dr. Mohammed Kilani is an assistant professor of clinical oncology at Ain Shams University. Dr. will address also immunotherapy in sarcomas and other rare tumors. Dr. Kilani, please.
Assalamu alaikum.
عليكم السلام ورحمة الله وبركاته.
Thanks, Dr. Ahmed Kabara, for this nice presentation. And thanks, EMOG Group, for inviting me for this lecture. I now share my presentation screen. Something wrong? Did you see my presentation or?
We see your desktop, Dr. Kilani. So just open your presentation and we see your desktop.
Okay.
Yes.
Okay. Now we shift from very common disease area, breast cancer, to the very rare disease subtype is sarcoma and rare malignancy. I have no disclosure. Based on Rare Cancer Network or EuroCan, they defined the rare disease as a prevalence below 50 per 100 million population per year in Europe. Also, rare cancer incidence is below 6 per 100,000 population in Europe, and what's called ultra rare, with the incidence is below than 1 per million per year in population. The rare disease is challenging because we have a lack of quality of information about this disease and the lack of scientific knowledge, which lead to lack of correct access to the diagnosis as well as delay in diagnosis. Collectively, this is lead to inappropriate quality of care giving to this cancer subtype and difficulty to access the treatment and the care. Breakthrough news actually in soft tissue sarcoma have been progressed very slowly. If we see in 2002, the imatinib take approval in just, and there is a breakthrough news because it make a paradigm shift in the management of just from chemotherapy to just oral TKIs, imatinib, or second line or third line TKIs oral chemotherapy. In 2008, meta-analysis showed that the single-agent doxorubicin versus any combination is ifosfamide is as equal as the single agent in a survival, but the difference in response rate. So we approve the single-agent doxorubicin in the advanced soft tissue sarcoma unless our aim is a symptomatic patient. We lead a rapid response rate. From 2008 till 2016. A lot of trials try to beat the doxorubicin alone, aldoxorubicin, palifosfamide, or ivosfamide combinations versus doxorubicin alone. All of this trial failed to show any survival benefit against single-agent doxorubicin. So single-agent doxorubicin never been beaten till 2016. In 2016, strange issue will come. Olaratumumab anti-EGF antibody has take accelerated approval from phase 1b2 trial, which improving overall survival when we use with doxorubicin versus doxorubicin alone, with the same progression-free survival. But this accelerated approval withdrew in 2018 because in the phase 3 trials show no benefit of this combo versus again the doxorubicin alone. Lastly, in 2020, we approved in the neck fusion metastatic solid tumors entrectinib or lorlatinib in the treatment of the metastatic solid tumors, including sarcoma in the pediatric and the adult soft tissue part sarcomas. Also, in the EZH2 mutation, tismostat is approved in epithelioid sarcoma. The concept of immune response to the cancer therapy is not so new. It is as old as 19th century when a surgeon called Wilhelm Schulz reported a phenomena of spontaneous tumor regression after special staphylococcal infection, erysipelas, in more than one patient, and which interestingly, this patient was has a soft tissue sarcomas in the disease, and this guy has a soft tissue sarcoma in the neck and make a recurrent twicely after surgery. The last one has infection of the staphylococcus infection. This guy reported a spontaneous tumor regression after this infection. He tried to correct a case series and published finally in 1921, and they tried to create some so-called Cooley's vaccine and to be used in advanced cancer patients. About the principle of the immunotherapy, the modern immunotherapy and its mechanism of action. Did you hear me? Hello?
يا دكتور محمد السلام عليكم. هو الصوت قطع ورجع تاني، دلوقتي سامعين حضرتك.
تمام. The principle of the modern immunotherapy mechanism, this is the immune cancer cycle. At the level of the lymph nodes, we take the break off through monoclonal antibody to inhibit the inhibition through the B7 CTLA4 ipilimumab. And at the level of the tumor microenvironment, again, we take the break off through monoclonal antibodies, anti-PD1 and anti-PD-L1, to take the inhibit the inhibitory effect of the tumor cell itself against the activated T cell. Another philosophy to stimulate the activated T cell, either in vitro, which we take the active T cell, as we will discuss in later on in so-called adaptive cell therapy. And this activated T cell will make an expansion and re-infuse or re-inject it into the body, or activate it in situ through the cancer vaccine. Here, if we look to the data published in 2020 in biomarkers in soft tissue sarcoma, actually we discovered that the tumor mutational burden in the soft tissue sarcoma as high as melanoma. But in the real practice, melanoma is show highly immunogenic, and the IO, it changed the paradigm shift in the management of the melanoma. In contrast to soft tissue sarcoma, the role of immunotherapy is still debatable and growing. We do believe that the main reason for this is that melanoma is a one tumor subtype. In contrast to the soft tissue sarcoma is at least 60 tumor subtype. And here the tumor mutational burden is vary from the leiomyosarcoma to the dedifferentiated liposarcoma or the undifferentiated pleomorphic sarcoma. Again, there is data about the PD-L1 expression also in the soft tissue sarcoma. The data is about 50%, 20 to 50% is expression in soft tissue sarcoma. GIST is highly expression to the PD-L1, and till now PD-L1 expression it carry a prognostic significant only, does not predict response to IO therapy. Also, tumor infiltrating lymphocyte CD8 positive show can be used as a prognostic biomarker for a better survival. And lastly, the cancer testis antigen, or so-called New York esophageal squamous cell carcinoma 1 antigen, which is found to be highly expressed in the synovial sarcoma and in myxoid fibrosarcoma or myxoid round cell sarcoma. Shift to the real world practice. Pembrolizumab is tested in the advanced soft tissue sarcoma and the bone sarcoma in the SARC-28. It is a phase 2 trial tested in 86 patients advanced soft tissue sarcoma and bone sarcoma. The patient population received at least 1 to 3 previous line of systemic anti-cancer therapy and at least have a 1 lesion accessible for a tumor biology and biopsy. Exclusion criteria as IO as usual, brain mets or uncontrolled medical disorder or autoimmune syndrome that contraindicate IO infusion. We give patient Pembro fixed dose 200 milligram every 3 weeks until disease progression. The primary endpoint is the objective response, and the secondary endpoint was immune-related response criteria and the progression-free survival. If we see here the waterfall plot about the response in the soft tissue sarcoma, we will see that the undifferentiated pleomorphic sarcoma with the most common sarcoma subtype give a response, and the leiomyosarcoma is the modest or the latest subtype give a response. It is only give a stable disease, no one give any complete or partial response. This clinical activity does not correlate with, again, the PD-L1 expression. If we shift to the bone tumor subtypes, we will see that the chondrosarcoma and the osteosarcoma give some response to the immunotherapy. The Ewing is the least to give this response. As regards the side effect, the grade 3 or 4 toxicity is below than 9% in all sample population. The most common was the nephritis or infection pneumonia or a pleural effusion or pneumonitis. Nivo is tested, Nivo with or without EB in the treatment of the metastatic sarcoma. Again, it is a phase 2 trial tested in advanced sarcoma in a patient with performance 0 to 1, received at least one prior systemic therapy. We randomized for Nivo 3 milligram every 2 weeks or Nivo plus Evo every 3 weeks for 4 doses, then a maintenance Nivo monotherapy for at least 2 years. The primary endpoint is the objective response rate, and the secondary endpoint is the duration of response, as well as the progression-free survival and overall survival. If we see the patient characteristics, this also including bone sarcoma in the patient's population subtype. The median progression-free survival was 1.7 in the mono arm in comparison to 4.1 in the combo arm. And again, the combo arm is a better for overall survival, 14.3 in months versus 10.7 to the mono arm. If we see the waterfall response rate, only 20%, 5 patients only give a response to the monotherapy Nivo. In combination, the response in 88%, which is give us the reason why the combo can be act better in sarcoma or other tumor subtypes like renal cell carcinoma or even breast cancer. We also test nivolumab in a patient with so-called ultra-rare sarcomas, the clear cell sarcoma and the alveolar soft tissue part sarcoma, which interestingly showing some sort of response or a durable response, especially for the alveolar soft tissue sarcoma. The collective response is reached to 70%. And the median progression-free survival was 6 months, and in clear cell sarcoma with the 4 months. And the median overall survival not reached. From this data published in Connective Tissue Conference 2020, the collecting a retrospective data for all patients of the alveolar soft tissue part sarcoma treated with anti-PD-1 or PD-L1 therapy worldwide. All patient number was 31 from 12 centers. This shows that the overall response rate near to 50%, the median progression-free survival is 10.9, and the median overall survival again not reached with 2 years survival about 87%. From this data, NCCN guidelines in 2020 put an immunotherapy as an option, especially to this peculiar subtype, the alveolar soft tissue part sarcoma. We go a step forward. We test the combination of the IO therapy with the anti-VEGF. This paper is published in Nature about the rationale why the hypoxic tumors lead to immune suppression, because the hypoxic tumor need to abnormal tumor vasculatures, and the abnormal tumor vasculatures will make immune suppression through the target cells of the endothelium and the dendritic T cells and the active T cells, even the T regulatory cells, because this hypoxia lead to malfunction, and the abnormal tumor vasculatures lead to abnormal tissue distribution or penetrations of these cells. In vitro studies show that the combination of the anti-VEGF with the IO lead to upregulation of the expression of the PD-L1 via the interferon gamma secreted by the activated T cell, and enhancing the sensitivity or the activity of the anti-PD-1 therapy. Also, the anti-VEGF therapy normalizes the tumor vessels and infiltration of the activated T cell. This is the rationale why we tested in a phase 2 trial axitinib plus pembrolizumab in the patient with advanced soft tissue sarcoma, including the alveolar soft tissue part sarcoma. It is a single center and single arm. They tested this combination in 33 patients. The overall response rate was 25. And again, if we look in the peculiar subtype, the alveolar soft tissue part, most of the patient give response is in the form of the alveolar soft tissue part sarcoma. And if we take this tumor subtype, the overall response rate again will reach to 50%. The 6 months progression-free survival is 47%, and the 12 months progression-free survival was 28%. And again, alveolar soft tissue sarcoma. With me now?
Dr. Kilani, your voice
you
is,
hear me?
Your voice is a little bit interrupted.
Yeah.
Sorry, Dr. Kilani is trying to reconnect. I think he has a problem in his internet connection.
Interrupted, yes. كيف؟
اتفضل دكتور محمد، دلوقتي رجع تاني.
Hello?
اتفضل يا فندم.
And again, I will go to the last slides about the adaptive cell therapy in soft tissue sarcoma. We collecting the T-activated T cell directly from the intratumor microenvironment. Here we collected the activated T cell, not required to be activated, and just we expand it in a cell culture and then re-infuse it into the patients. Another mechanism that we collect a peripheral T cell, then make inside it to what's called T cell receptor redirection technology or activation by genetic engineering. It is either we put inside it a T cell receptor to be a high affinity T cell receptors, and this required that the T cell to be activated inside our body through the dendritic cell with an antigen attached to the MHC. Or another smart theory that we call CAR cell therapy. Here we attach a part of the antibody against the tumor antigen in the extracellular part of the TC receptor. And also we connected a part of the CD8 receptor to make this receptor continuously active when it attached to the antigen. So in the CAR therapy, the T cell which is injected to the body does not require a reactivation by the dendritic cells. Now, synovial sarcoma, as we told in the previously, that it is expressing the cancer testis antigen with highly expression, 70 to 80%. We try to test a LUT cell, which is an autologous CD4 positive and CD8 positive T cell, which has been genetically engineered to express a high affinity TC receptor against the cancer testis antigen. In a phase 1, which is tested clinical trial safety and efficacy of the LUT cell in the patient with advanced synovial sarcoma. Here, this trial is including any synovial sarcoma unresectable or metastatic or recurrent. They design it in a 4 cohort according to the expression of the cancer testis antigen and the regimen used for lymphodepletion regimen. Cohort 1 was high expression to the cancer testis antigen, and the lymphodepletion regimen is a high dose fludarabine plus cyclophosphamide. The cohort 2 is low expression, and we use again high dose fludarabine and cyclophosphamide. The cohort 3 is a highly expression to the cancer testis antigen, and the regimen only cyclophosphamide. And the cohort 4 is a high expression to the cancer testis antigen, and we use a low dose fludarabine and cyclophosphamide. If we see the study design, it is like the bone marrow transplantation. First part, we do leukapheresis. Then this leukapheresis, we make a genetic engineering to create what's called LUT cell therapy, which is a high affinity T cell against the cancer testis antigen. Then part 3, we do a lymphodepletion with different regimen using fludarabine and cyclophosphamide. Then we re-inject the LUT cell infusion to the patient, then follow-up. The result, the best to give the response rate is the cohort 1, which is a high expression to the cancer testis antigen and use a high dose of the fludarabine and cyclophosphamide. And it is also a high for the median overall survival. The next cohort to give overall survival is the cohort 3. And the next for the response rate is the cohort 2. If we use the cytokine as an biomarker for this therapy, we found that the interleukin-15 is correlated with the response directly in the pre-infusion. In the post-infusion, both interferon gamma and interleukin-6 and the interleukin-2 RA is also appear as a promising biomarker for a response. In conclusion, the mutational burden in soft tissue sarcoma is as high as melanoma, but the mutational frequency is vary according to the subtype. The PD-L1 and the CD expression in soft tissue sarcoma considered as an emerging prognostic biomarkers. The cancer testis antigen is highly expressed in the synovial sarcoma. IO immunotherapy in the form of the pembrolizumab or in a combo Nivo plus Evo has a promising efficacy, especially in undifferentiated pleomorphic sarcoma and modest efficacy in the leiomyosarcoma. Epichlorial sarcoma subtype is the alveolar soft tissue part sarcoma and the clear cell sarcoma with a given response to immunotherapy plus or minus anti-VEGF. In a phase 1 study, we use LUT cell infusion with lymphocytic depletion, give a clinical meaningful activity against synovial sarcoma. Lastly, with deep regret, we lost our deep professor Amr Lotfi yesterday, rahmatullahi alayh, and thank you.
Thank you, Dr. Muhammad, for this nice presentation.
Sorry for internet interruption.
No problem. Now, if any one of the attendees want to ask Dr. Muhammad any question about the immunotherapy in sarcoma, please present to us in the Q&A. Dr. Belmont. I think we didn't receive any questions, and we are 5 minutes beyond the time. So let me introduce our next speaker. Our next speaker is Professor Joachim Pelmont. Professor Joachim Pelmont is the Director of Bladder Cancer Program at Beth Israel Deaconess Medical Center, Associate Professor of Medicine at Harvard Medical School in USA. Dr. Pelmont has a lot of publication in the field of urothelial carcinoma management, and he is the principal investigator of the Keynote 45. Really, it is an honor to have him to present a keynote lecture about IO in urothelial malignancies. Dr. Pelmont, you can start.
All right. So first of all, thank you very much for the invitation. I don't know if you see the screen.
Yes, yes.
The first slide. Yeah, so I think that's a really interesting. I was able to hear these two last lectures, especially I didn't know that there are some sarcomas that can benefit from immunotherapy, and yeah, I learned. So it's yeah, you're doing this nice approach with this cellular therapy that it's likely where the immunotherapy is moving now forward in different diseases. So my topic today is going to be the role of immunotherapy in urothelial cancer. However, if you allow me, and Professor Ahmed allows me, I'm going to talk a bit also about other therapies. I think that this year has been outstanding, fantastic, because we have seen some new options for our bladder cancer patients, although these options are not available worldwide. Here in the US, we know that sometimes the approval are quicker, and even you can start prescribing a drug if you have like evidence that is working. And this makes so patients being much more treatable even in with these new therapies. So with that, let me see if I can use this moving forward. All right. Yeah, here are my disclosures. And here you can see it. This is a summary until 2020. So and we have been working with bladder cancer for like around 25, 30 years with different combinations, chemotherapies, some minor improvements. We had the approval of Influnin in second line only in Europe and other areas of the world. And it's not until 2014 when the emerging role of immunotherapy is showing up in bladder cancer. And then in 2016, we were able to get approval for in second line and beyond of 5 therapies, atezolizumab, durvalumab, avelumab, nivolumab, and pembrolizumab. But the thing has not stopped here in this second line setting. We had new targeted therapies. This is April 2019, FDA approved this agent, but it's a targeted therapy against FGFR3. And also much more recently, we have seen the results, and I will shortly present the results of this phase 3 trial of enfortumab vedotin that is now also a good option for our patients. So that's the scenario. Let's review. I will start first the first trials. Those are the first trials that lead to the approval of all these 5 agents in patients who failed platinum-based therapy. And as you can see here, all these 5 drugs, atezo, pembro, nivolumab, avelumab, durvalumab, they provide around 20% of responses to our patients. Not a huge amount of responses, but the best thing is that these responses were good quality of responses, meaning that some patients got these responses. Those were long lasting, and now we know that there are patients surviving beyond 3-4 years. And also we saw, based on these trials, second line, third line, and beyond, the median survival was not what we saw in the chemotherapy trials like Influnin, 7 months. We saw some improvement in survival, and this led to the approval of these agents even before having results of phase 3, at least here in the US, and some of them are still being used worldwide. So obviously, based on these phase 2 trials, there was a need to show that there was an evidence of efficacy for immunotherapy versus chemotherapy. This is the only trial, the phase 3 trial, that led to the approval of pembrolizumab in second line patients failing platinum-based therapy. This is the Keynote 45 that I had the privilege to lead this trial. This is, I mentioned this is the only one because the second one that we're going to see, despite showing good responses, the statistical analysis was not significant. We can see here comparing patients in the second line pembrolizumab versus chemotherapy, that could be paclitaxel, docetaxel, or bimflunin. Then you see that the survival favoring pembrolizumab, median survival 10.3 months in the pembrolizumab-treated patients, 7.4 in the chemotherapy-treated patients, with a hazard ratio of 0.73. And also, benefit was seen in patients with a CPS score more than 10%, but what we can see here, and this might be a topic for other discussion, patients with a PD-L1 positivity in the second line, they had an inferior median survival, meaning that the PD-L1 staining was more a prognostic tool than a predictive tool. Also, the response rate was higher for pembrolizumab, 21% versus 11.4%, and these obviously lead to the approval of pembrolizumab in the US and other parts of the world. So, and then we have the second phase 3 trial with similar design, second line, and patients failing platinum, atezolizumab versus chemotherapy. The difference here is that the main endpoint was overall survival in PD-L1 positive, so immune cells 2+, 3+. And here, as mentioned, despite that atezolizumab did its job, so median survival was 11 months, for whatever reason, patients receiving chemotherapy, and someone has been blaming bimflunin for that. So the patients with chemotherapy had a median survival that was superior of what was expected. Despite the fact retrospective analysis, because this was a hierarchical type of design, so the trial got stuck here, meaning that this was statistically non-significant, as you can see here, the p-value of 0.4. Other subsequent analysis did show that there was some benefit in intention to treat population for atezolizumab. So that's the first set of trials that lead to the approval in the second line. And obviously, a lot of work was done in patients who were platinum ineligible, being in the first line setting. And here you can see the two trials, the phase 2 IMvigor cohort 1, showing atezolizumab providing some benefit in those patients receiving first line immunotherapy being platinum ineligible. And as you can see here, the median survival in these first line platinum unfit patients, 15.9 months, and for the pembrolizumab, also close to 12 months. And as mentioned, the duration of response was outstanding in some patients receiving immunotherapy. And this led to the initial approval of these two agents in first line in patients who were unfit. But then, because of the results of the phase 3 first line were available, there was some refinement on this indication, and only patients being PD-L1 positive were allowed to receive first line atezolizumab or pembrolizumab. Or in the US, we have the option in patients who are ineligible for any type of chemotherapy. So that's the first line setting, patients being unfit. And then obviously the question was, is there any role for immunotherapy in the first line setting or combining with chemotherapy? And here you can see the list of the five randomized phase 3 trial that in first line setting, including patients who are platinum eligible or platinum ineligible, comparing in the majority of these trials, immunotherapy versus chemoimmunotherapy versus the standard of care chemotherapy. The only difference is this one, the DANIEF trial, where immunotherapy is compared to two different types of immunotherapies, the PD-L1 plus CTLA-4 or chemotherapy. But here the IMvigor, the Keynote 361, similar design, in this case, pembrolizumab compared to carbo, gemcitabine, or the pembrolizumab alone. So we have now results for the first 3 trials. Still, we wait for the results of the Checkmate and 901 and the Nile study that are still close to be completed, the accrual. And these results were initially presented at ESMO and then published in Lancet Oncology. You can see here, this is the IMvigor 130, where immunotherapy plus chemotherapy is being compared with immunotherapy in monotherapy or placebo platinum gemcitabine, and this could be carboplatinum or cisplatinum. Those are first-line patients, including platinum eligible and platinum ineligible. The primary endpoint was progression-free survival and overall survival. And the results that were presented at ESMO initially did show that the progression-free survival was significant in patients receiving chemotherapy plus immunotherapy, atezolizumab plus platinum gemcitabine or carboplatinum gemcitabine. However, the survival was not statistically significant despite this p-value because this was an interim analysis. So still we are waiting this trial to get mature to see if there is a survival benefit in this first-line setting. So initially, this is a combination that is not yet approved because only PFS was shown to be statistically significantly positive. And then we heard the results at ASCO and ASCO-GU of the KEYNOTE-361, similar design, immunotherapy versus chemotherapy plus immunotherapy, in this case pembrolizumab, versus the chemotherapy that, again, could be platinum or carboplatinum. And here, what we saw for this trial that has not yet been published, the results that were presented at ESMO showing that this trial didn't meet the pre-specified endpoint of overall survival or progression-free survival. So this trial was completely negative, despite that if we compare the PFS in the IMvigor 130 or in this trial, the KEYNOTE-361, we can see that the curves are quite similar, and the median PFS is quite similar, 8.3 months versus 8.2 months. Here is 7.1 months because in this trial, this was the PFS was independently assessed, while in this trial was investigator assessed. And if you see the comparison, this one is statistically significant, the IMvigor 130, while the KEYNOTE-361 is non-significant because of that, 7.1 months versus 8.3 months. But then if we move to the PFS by investigator, we see that these trials are completely the same. But because this was not the primary endpoint, this trial ended up on being negative because of the PFS. But we see more or less similar results with these two trials in first line. And then when we take a look to the overall survival, the same. So the differences are more or less identical, as you can see here. In the KEYNOTE-361 or the IMvigor 130, we can see 17 months versus 14 months, 16 versus 13, so 3 months difference. But because of the design, the statistical design, this trial negative, this one still immature. So we need to wait for the final survival data for the IMvigor 130. The third trial in first line has also already been published. In this case, immunotherapy with the PD-L1 durvalumab versus durva-treme, the PD-L1 CTLA-4 versus chemotherapy. Again, first line. Here, the endpoint was overall survival, durva versus standard of care in PD-L1 positive, trying to enrich the endpoint here, and also overall survival, durva-treme versus standard of care in all comers. This trial, these two primary endpoints completely negative. So you can see here that in one of the primary endpoints, durvalumab versus chemotherapy in PD-L1 high, no differences. Durva-treme versus chemotherapy in the intention to treat, again, non-statistically significant differences. The only thing that was found interesting in this trial is that when the comparison was done in between durva-tremelimumab versus chemotherapy in the PD-L1 positive population, this was positive for survival. Again, here, this was not a primary endpoint. This was a secondary endpoint, meaning that this trial was finally negative. But this finding has been implemented on the Nile trial, where durva-treme chemotherapy is being compared to chemotherapy plus durva versus durva. So, and this may change the primary endpoint of the Nile study, that is using the same drugs, but adding chemotherapy. So the conclusions on this first-line setting, the IMvigor 130, the KEYNOTE-361, or the DANUBE, we have seen that the chemotherapy in first line is difficult to beat in urothelial cancer. It's not the same as we have seen in lung cancer or head and neck cancer. We see that there might be an antagonistic effect, even on the duration of response that we are going to see now. We know that starting immunotherapy as monotherapy is not an option in all patients. Maybe is in patients being unfit, but the question is that we see that patients receiving monotherapy with immunotherapy, the survival curve in the very beginning are below compared to those receiving chemotherapy. And obviously, we need to identify which are the patients that are going to benefit from these approaches, and biomarkers need to be implemented in all these trials. So here, what I'm showing is that the response rate and duration of response in all these trials. And what you can see here, that it seems that combining chemotherapy and immunotherapy is blunting the response rate. We can see here in the atezo platinum gemcitabine versus placebo platinum gemcitabine, the response rate 47 versus 44. If we see that in the Keynote 361, 54 compared to 44.9. So we don't see an improvement in response rates when we are combining chemotherapy and immunotherapy. But another thing is that the quality of the responses seems to be lost when we are doing that. If you see here, the responses in patients receiving chemotherapy plus pembrolizumab, the median duration of response is 8.5 months. In the atezolizumab chemotherapy is 8.5 months. However, if you pay attention to the responses obtained with immunotherapy in monotherapy, those are good responses. We see that median duration is 28 months in patients responding to pembrolizumab, not reached for atezolizumab, but also you can see that the boundary is 15.9 months. And also for durvalumab, again here, we can see that the median duration of response are higher. So it seems that even the duration of response is being blunted if we combine chemotherapy with immunotherapy. Maybe we need to learn much better how to combine chemotherapy and immunotherapy. And again, I mentioned that in all these trials, we see that patients receiving monotherapy with immunotherapy, the survival is inferior. So likely starting with immunotherapy is not a good approach. We also confirmed that in our presentation at ESMO with this trial, that the Inducomain. The Inducomain was in a first-line trial where patients being unfit were randomized to receive carbogemcitabine or induction, that is the word induction immunotherapy, concomitant chemoimmunotherapy, and maintenance immunotherapy with avelumab. So we were thinking, well, if implementing immunotherapy with chemotherapy, likely we're going to beat chemotherapy in this first-line setting. What we saw here again, patients, we lose the patients receiving this induction immunotherapy only. You can see here 1/3 of the patients progressing and dying, although in the end, the survival was like favoring the combination of chemoimmunotherapy. Finally, this trial was considered to be negative. Here again, the response rates of chemoimmunotherapy versus chemotherapy, almost no differences. So chemo and immuno, we are blunting the percentage of responses, the quality of the responses, and it's not a good option to start with immunotherapy as monotherapy in these patients. So just to summarize a bit, immunotherapy plus minus chemotherapy, is this a new standard of care in first line? So not yet. We need to wait for the final overall survival for the IMvigor 130. In all cisplatin eligible PD-L1, no. Only in cisplatinum ineligible patients, maybe there is a role for immunotherapy. And we know that atezolizumab and pembrolizumab are drugs being approved. And then we have seen the second line, the very beginning, the first line setting, but there is one space that is like in the first line that is immediately after the first line that is in the maintenance space. So what to do in those patients that receive chemotherapy and then we usually wait? What's the role of adding something else after the first line therapy? And until 2019, we said that there was no role of maintenance therapy in metastatic bladder cancer. We remember the sunitinib versus placebo trial, the lapatinib versus placebo trial, those trials being completely negative. We heard that 2 trials came with positive results. So the first one was the bimflunine maintenance, meaning instead of giving bimflunine as second line, we put bimflunine as maintenance. And this was published in Lancet Oncology. There was a benefit in progression-free survival. Unfortunately, the trial was not powered enough to show an overall survival, and the overall survival was negative. But as mentioned, this was a small randomized phase 2 trial, but there is a role for bimflunine maintenance. And also this other trial that is now published in Lancet Oncology by Dr. Galsky, where pembrolizumab, after first-line chemotherapy, provide the benefit in progression-free survival, although the overall survival was not achieved. And finally, what has changed our standard of care is the study, the Javelin 100, where avelumab, this PD-L1 inhibitor, is being used in this maintenance space. You can see here the design of this trial. This trial was presented as a plenary session at ASCO, and then it has already been published in the New England, first author being Tom Powell's. You can see here that patients receiving chemotherapy, that could be platinum gemcitabine or carboplatinum gemcitabine, if the patients were obtaining chemotherapy benefit, meaning non-progressing, either obtaining a complete response, partial response, or stable disease, randomized after 4-6 cycles of chemotherapy, and then after a period of time, an interval between 4-10 weeks, to receive avelumab maintenance until disease progression or best supportive care alone. Primary endpoint, overall survival. And as you can see here, all the endpoints were measured post-randomization. And this is really, really important to see the magnitude of benefit of this approach in bladder cancer. So this is the paper. So I was in the steering committee just designing this trial because I was involved in the BEAM-FLUIN trial. And as mentioned, the full trial is now published in the New England Journal. So here are the results of the Javelin. The interim analysis, in fact, was what was presented. We can see that this trial met its primary endpoint, that was overall survival in the overall population and also in the PD-L1 positive population. You can see here that the magnitude of benefit of this survival advantage is 7.1 months. So you can see here, best supportive care median survival of 14.3 versus 21.4. This 7-month benefit is the biggest magnitude of benefit we have seen in metastatic bladder cancer patients. And also an important thing is that the benefit was seen in patients either receiving carbogemcitabine or platinum gemcitabine. So likely the patients receiving platinum gemcitabine had a much better outcome than the others, but the benefit was seen in both. And also another important thing is the benefit was seen in patients with stable disease, CR or PR, when receiving this maintenance avelumab. Here you can see the survival curves. Obviously, the maximum benefit is seen in those patients obtaining a partial response, less benefit in patients with stable disease, and less in patients obtaining complete response. But this was not a pre-specified or pre-planified endpoint. So here you can see here the benefit seen in different subgroups. And one important thing is that giving avelumab as maintenance did not impair the quality of life. This is a quality of life specific for bladder cancer, and also this like wider quality of life type of score, that is the EQ5D5L, showing there is no detrimental effect when giving avelumab maintenance. Side effects, as expected, 11% of treatment discontinuation in the majority of cases because of infusion reactions. And the profile is what we know for avelumab in the metastatic second-line setting. So also there was some subgroup analysis presented at ASCO GU quite recently, and one of the questions was: do we need to give 4 cycles, or do we need to give 6 cycles? The trial was not designed for that, but the conclusion of this analysis, it showed that the benefit is either seen in patients where the switch maintenance is done after 4 cycles or after 6 cycles. So that's what we have we have seen second line, first line unfit, first line chemoimmunotherapy, and this maintenance space. If we are moving with immunotherapy in earlier spaces, we are moving to the muscle invasive space. You can see here now we have 4 fully published trials using, and those are phase 2 trials. So we don't have randomized phase 3 trials. Those are accruing. We have some results that we're going to see in the adjuvant. Those are neoadjuvant. There are 4 published trials, and these trials have been published in pembrolizumab in JCO, the Atezo, durvalumab, and Ipi/Nivo in Nature Medicine. So with a lot of biomarker results. And then we have 2 additional trials, platinum gemcitabine, nivolumab, or durvalumab, presented at ASCO or ASCO GU. So one important thing for these trials is that we see that the pathologic complete responses are really, really high. 40%, 30%, 41%, 46% in this neoadjuvant setting. So likely there's going to be a role for immunotherapy in the neoadjuvant setting. Obviously, this has led to the design of trials in the neoadjuvant setting that are accruing. And then obviously the same concept has been implemented in the adjuvant setting. So moving from neoadjuvant to the adjuvant, we have these 3 trials, the pembrolizumab versus observation, the Ambassador trial, we have the nivolumab versus placebo, and we have the IMvigor010 atezolizumab versus observation. And the last one, the IMvigor010, was the one that was presented at ASCO and has been recently published in Lancet Oncology. So that's the trial, adjuvant atezolizumab versus observation in muscle-invasive urothelial carcinoma, meaning that patients after surgery or after having received neoadjuvant or not being eligible were randomized to receive atezolizumab or observation. I was the PI of this trial. Unfortunately, I choose the trial that ended up on being negative, but because we're going to see that some interesting data with nivolumab in the same setting of adjuvant therapy. Here is the design of the IMvigor010. Patients after cystectomy, having or not received neoadjuvant, if there was disease there, randomized to receive 1 year of atezolizumab versus observation. The main endpoint, disease-free survival, and unfortunately, as mentioned, this endpoint was not met. We can see here the PFS 19.4 months, and remember this number because it's quite similar to the nivolumab study. Observation 16.6 months. You can see here pretty close, and this is what is completely different from the nivolumab trial and that we're going to see later on. It seems that there is a benefit in the very beginning in PFS, but then likely here is when the immunotherapy stops doing its effect, so the DFS curves converge. So now what we see here, this is accruing the ambassador, the IMvigor010 negative trial, and we saw at ASCO GU the results of the Checkmate 274 trial that is as similar as atezolizumab, the IMvigor010. Patients were randomized after surgery to receive nivolumab versus placebo. Here is the slide that was presented by Dean Bajarin at ASCO GU. As mentioned, similar design, patients after surgery having received neoadjuvant or with residual disease after surgery, meaning lymph node positivity or extravesical extension, being unfit for platinum, randomized to nivolumab versus placebo. And this is another difference. This was not observation like the IMvigor. And this obviously also might make these trials quite different. This was placebo, patients receiving every 2 weeks intravenous infusion for a year that they didn't know if this was treatment or placebo. This trial met its endpoint. You can see here and this is disease-free survival in the nivolumab-treated patients, 21.1 months versus 10.9 months. You remember this was 19.3 or 4 for the atezolizumab trial, 16 for the atezolizumab, 10.9 for this placebo nivolumab trial. And this makes this trial different. Whenever we are jumping to the PD-L1 positive, we see that the hazard ratio instead of 0.70 is 0.53. So benefit in patients with PD-L1 positive more than 1% in this Checkmate 274. Benefit seen across different tumor types. I'm not going to the patient characteristics. Also other endpoints, the non-urothelial tract recurrence, the distant metastasis-free survival. These secondary endpoints were also met in this trial. So still, this trial has not been published. However, nivolumab is likely going to be a potential option because the main endpoint that was progression-free survival was met. And there are other trials in this perioperative bladder cancer space. We have the Niagara, that is neoadjuvant plus adjuvant, the CA 017-078, that is using chemoimmunotherapy, or we have these others using also enfortumab vedotin plus pembrolizumab in the neoadjuvant setting, or using, again, here in patients who are ineligible, or finally here, this IL-2 combination of nivolumab, but with this compound that, as mentioned, the NKTR-214, that is an optimized way of giving IL-2. So we're going to see interesting results in the next coming years. So concluding in the chemotherapy and immunotherapy in the perioperative setting, neoadjuvant, still chemotherapy in patients who are platinum eligible is the standard. Immunotherapy, interesting data coming from these phase 2 trials, but we need to wait maybe in the future. For adjuvant, chemotherapy still is an option to give chemotherapy to these patients. For immunotherapy, based on ASCO and the Lancet Oncology, the IMvigor010, no role for atezolizumab, but for the Checkmate 274 progression-free survival benefit, we don't know still if this is impacting on overall survival. And this is what people is questioning. If this trial is only positive for progression-free survival, are we going to use a nivolumab as adjuvant after surgery? So we'll see how the future deserves in terms of the survival. So moving to the earlier spaces, it is a non-muscle invasive space. You know already the results in patients failing BCG, in having CIS, where pembrolizumab, we have these approved in the US, and there is several other countries with pembrolizumab being approved with 40% responses at 3 months in patients who have failed BCG, having high-grade non-muscle invasive with CIS. Just to mention, although this symposium is for immunotherapy, I believe that we need to briefly mention the advances with targeted therapies. Now we have all these 3 targeted therapies, erdafitinib, approved in the US, enfortumab vedotin, and sacituzumab govitecan, that are providing more or less the same responses. For erdafitinib, patients need to be FGFR selected. Mutations in FGFR2 or 3 or translocated, 40% responses, median overall survival in second or third line of 13.8 months. As mentioned, this is approved. We don't have phase 3 data. And we have these new emerging drugs, the antibody drug conjugates, similar to the TDM1 that we use for breast cancer, where monomethyl auristatin is being used in treating bladder cancer patients. Here, we are using a target that is Nectin-4. We don't need to test the patients for the Nectin-4 expression because we know it's widely expressed in bladder cancer. The other similar compound is sacituzumab govitecan. Here, instead of monomethyl auristatin, we use the NS38, that is a metabolite of irinotecan. And here you can see the results with enfortumab. In unselected patient population, in the phase 2 trial, we saw, again, 43% of responses, median survival of 12.3 months. But the most interesting thing is that now we have the results of this phase 3, the EV301, that has also been published in the New England Journal, where in third line, meaning patients that fail chemotherapy and immunotherapy, patients were randomized to enfortumab vedotin versus chemotherapy, and there was a survival advantage in patients receiving enfortumab vedotin in this third line space. As mentioned, in the US, was already approved and likely is going to be widely approved around the world because of the survival advantage that is of 4 months. So here is the paper that, as mentioned, this was published on last month, February 12th. Again, here, the first author, Tom Powles. And then there are other trials coming, obviously, with this enfortumab vedotin. Here, I'm not going to go through the results. And I have been talking about enfortumab vedotin, but because of the importance of combining chemoimmunotherapy using antibody drug conjugates, looking likely for this chemotherapy or immunogenic cell death that we see with chemotherapy. And we have data, some preliminary data on the combination of enfortumab vedotin plus pembrolizumab that was presented in Barcelona 2019. There was a phase 2 trial where in patients first-line bladder cancer unfit for platinum, we saw a response rate of 72%. So exciting. And this is why this combination is now moving in the first line, in the neoadjuvant, in the adjuvant. So likely it is going to be a combination for the future. So this is an algorithm in 2018 that we just published before enfortumab vedotin being approved. This has completely changed, meaning that the field of bladder cancer has changed quite quickly. We can see here what's happening in 2021. We have pembrolizumab in CIS, BCG refractory. We have seen the interesting data on the neoadjuvant. We have seen in the adjuvant the results of the Checkmate 274, the nivolumab in the adjuvant setting. Chemotherapy and immunotherapy, we need to wait for overall survival for the IMvigor. We have seen this 7 months difference in survival using avelumab maintenance after first-line therapy in patients who are responding or having stable disease. Some data for pembro and bimflunine in the maintenance space, and finally, these new 2 targeted therapies, enfortumab vedotin and erdafitinib. So those are the guidelines that have been modified to add avelumab, and also this is now the new version where the maintenance avelumab has been implemented. In the US, we have enfortumab vedotin, and we have erdafitinib, and also we have the maintenance avelumab after first-line chemotherapy. Likely is the main advantage that we have seen, or the best trial ever seen in metastatic bladder cancer patients, these 7 months improvement using maintenance avelumab. Take-home messages in this metastatic setting. We were expecting changes in first line that we didn't see. We were disappointed by the Keynote 361, the DANUB. Still, chemotherapy in metastatic disease is the standard of care. We have maintenance avelumab as the newest standard. We have a first-line atezo pembro in platinum ineligible who are PD-L1 positive. Second-line immunotherapy based on the Keynote 45 is also standard of care. Those are the 3 settings in the metastatic disease. Obviously, we are seeing long-term survival, patients surviving after immunotherapy that we didn't see before. We have these new targeted therapies, enfortumab vedotin and erdafitinib, that are new options in second and third line. But finally, the future is going to be obviously driven by the biomarker. And I'm happy to discuss some of the trends that we are now using for the new trials in the adjuvant setting or the neoadjuvant setting. So with that, that's my last slide, and I will be more than happy to answer questions or whatever is coming from the audience.
Thank you, Dr. Pelmont, for this comprehensive, excellent presentation. Really, we all learned from this talk. Let me start, as I am hosting this event, let me start with my question. You discussed the adjuvant, in the adjuvant setting, 2 trials, the atezo trial and the bimbo and the nivo trial. Why the difference, the huge difference in the control group, not in the immuno arm, in the control group? There is a huge difference between the 2 trials. You have an explanation of this?
Well, we don't have a definitive explanation, but you can imagine that a lot of meetings discussing why one trial is positive, why the other is negative. The question is PD-1 better than a PD-L1? Then you say, well, in this case, PD-1 is positive, but in the avelumab maintenance is a PD-L1. So we can remove that from the question, right? But then the other thing is that I think that one of the main important things is that, as you can see, in one trial, it was like observation. So patients, can you imagine you are a patient that after surgery you have lymph node positive and coming to me and I'm offering you receive atezolizumab or nothing. And you said, well, nothing? And if you are assigned to the nothing arm, observation, it's not placebo, it's nothing, right? Observation. Having lymph node positivity, are you happy? Likely no. And we don't know what happened with these patients. So this is what the difference on the PFS between the IMvigor010 and the nivolumab treated patients, that those were really placebo. In the Checkmate 274, patients came to see you and said, well, I have this trial that is blinded. You're going to receive every 2 weeks a treatment, IV, and maybe you receive immunotherapy or nothing. And then that means this is much more precise, much more blinded. And one of the questions that was in the Twitter saying, we might need also to compare, because PFS is depending on how you review the scans and how many scans you do and the time interval, right? So this difference in PFS in the, let's say, control observation population that make one trial being positive and the other not. So likely this might matter. So, and as mentioned, observation versus placebo, you see this PFS in one is 10 months and the other is 16 months. So why in this non-treated patient, the similar patient characteristics, we haven't found any difference, in fact, in between the populations of patients treated.
You think that the patient in the atezo trial, they had delayed diagnosis of relapse, for example?
No. I mean, if the PFS is shorter, is delayed, well, what happened here? Maybe you forget, or patients were not well followed in an accurate way. So that is how the CT scans were read. So I think that's very important. And it's something that obviously the companies that are interested in this setting are like exploring now.
Okay, my second question is about immunotherapy in the first-line metastatic setting. Immunotherapy in bladder cancer or in urothelial cancer almost succeeded in all the stages of treatment. Why it didn't add any benefit to chemotherapy in the first-line setting? This is so strange.
Yeah, so we were trying in the INDUCOMAIN, this trial that is not yet published, we reported at ESMO, we're trying to answer that question. We knew about the lack of benefit when giving together. In this INDUCOMAIN trial, the mistake we made is to start with immunotherapy as an induction. Likely, we need to have started with chemotherapy and then move to chemoimmunotherapy. But the way that this trial was designed in the chemoimmunotherapy combination is not giving the first day platinum, gemcitabine, and immunotherapy. Immunotherapy was given on day 15. So because there might be a potential interaction, a negative interaction between the chemotherapy and immunotherapy. So in this trial, obviously we failed because the induction immunotherapy was not good enough. But I think that maybe bladder cancer is a different disease, and it's not like head and neck or lung cancer. But I think that still we cannot say chemoimmunotherapy is useless. Maybe exploring different type of ways of giving, maybe first chemotherapy and then on day 15. This is what I'm doing in some patients that are saying, well, I want to receive whatever. Now, obviously, with the javelin, obviously, you know that the sequential therapy is much better. So you start giving chemotherapy and then
maintenance, switching maintenance. Yes.
So still, we don't know why this failed. But we have seen the responses lower, even the duration of responses are not as good as with immunotherapy only.
Okay, if anyone of the faculty would like to discuss with Dr. Belmont any question or any one of the attendees, please send your questions on the Q&A section. Dr. Ahmed Ali, I think you want to discuss something with Dr. Belmont. Okay, I'd like to thank you, Dr. Belmont, and if I receive any question, I will send them to you. Thank you for your time. I was honored. We all are honored to have you with us today. Thank you, and I hope we have further collaboration together in the future. Thank you, Dr. Belmont, for your time. Thank you.
Have a good day, Silvan. Bye-bye.
Thank you. By this, I would like to end this part of our meeting, and we start the second part of our meeting. Actually, the second part of our meeting will discuss the lung cancer with all its different perspectives. We'll start from first line non-small to second line non-small, and then we end up with the small cell lung cancer and mesothelioma. Let me introduce now our next speaker, Dr. Maya Azzeddin. Dr. Maya Azzeddin is my dear colleague. She's assistant professor of clinical oncology at Ain Shams University, Cairo, Egypt. Dr. Maya will give us a presentation about immunotherapy in non-small cell lung cancer first line. Does it fit all? Dr. Maya, please.
Hello, can you hear?
Yes, Dr. Maya, we are seeing you and hearing you well.
Okay, great. It's really a privilege, and thank you, Dr. Ahmed Gaballa and all the EMOG team for having me and hosting me here. Okay, now I want to share my presentation. Okay, so I hope you can be seeing my screen now.
Yeah, perfect. Yeah, I can start.
Bismillah ar-Rahman ar-Rahim. IO first line non-small cell, does it fit all? This is a question we will be trying to answer through my presentation. I'll be discussing briefly stage 3 and stage 4 first line, because we're going to have a comprehensive review of all non-small cell lung cancer. And what is the outcome of lung cancer according to the latest staging system? Well, really, we're concentrating, as I said, on stage 3 and 4, where most immunotherapy lies and currently. And we can see that a big percentage of patients are in stage 3, majority of the patients, and also in our area or region of the world, I'm sure we all agree that we do see a lot of advanced and metastatic cancer patients. And what about their outcome? So at best, half of your patients by 2 years are dead if you're stage 3A, and 10% if you're the latest stage 4B, and 5 years survival if only a third of patients at best survive, with up to no survivors at all. So very dismal outcome indeed. And for years, we've been building the base of platinum-based therapy with our different regimens all having similar median survival and 1-year survival in the range of 30-something%. And since they were not that effective, attempts were being made to, I guess, decrease the toxicity of these agents. And perhaps 4 cycles was enough, and perhaps pemetrexed was better for non-squamous histology. And maintenance approaches were pursued just to pass that 1-year mark with bevacizumab and pemetrexed. And not only was it just an evolution in lung cancer, the discovery of the minute details that we see in this on the cellular level of the cancer cell, but was really quite a revolution with EGFR, ALK, ROS, MET, and KRAS hopefully soon will be targetable, but still yet remained the larger portion of lung cancer patients were non-targetable, and nothing addressed these patients, unfortunately. So it was time to sort of shift gears from thinking on a cellular level or a single target and starting to sort of think outside the box. If we can harness something that is already there and is existing in our background and has been, of course, the lectures have been the background lectures of the immune therapy use, how we can harness our own immune system to combat the cancer. And the PD-1, PD-L1 interactions, CTLA-4 are most of, have been the talk of the, I guess, the couple past years. And many agents have been developed. And the interest even from this early trial for non-small cell lung cancer, of course, in heavily pretreated patients, the beauty of immunotherapy in lung cancer is here. We see still there is a decline. Still, it is not that promising, but look here, look at the tail. It's all about the tail. Some people, some patients at 5 years, and these are heavily pretreated patients, some are surviving. Who are these patients? And with not a very toxic profile. So it was something definitely a positive light worth pursuing. And for years, or I guess not years, a couple of years, we've been trying to pursue how to select these patients, how to find these patients who will respond. And you could see from this pie, PD-L1 level is the most talked about. We have other markers such as tumor mutational burden and perhaps immune cell markers on the tumor, perhaps even just basic, neutrophil lymphocyte ratios. But in the end, PD-L1 seems to be the most established marker in most of the trials. But is it enough? Well, it's not perfect. As we target our tumor, sometimes it's kind of heterogeneous by its innate nature, but also PD-L1 can be heterogeneous. So it depends on which area of the tumor you do target, actually. And we must not forget it is something that is dynamic. It is changing. It depends on what stage you're in, pre, post therapy. It's basically you're targeting something in a continuum. And these are the agents that I will be discussing with lung cancer: PD-1 inhibitors, nivolumab, pembro, and cemiplimab, CTLA-4, ipilimumab, and tremelimumab, and PD-L1 inhibitors, atezolizumab, and durvalumab. And there are so much more, but still ongoing in the pipeline. So let's start briefly with a small touch on stage 3. For many years, we've seen the standard of care, concomitant chemoradiotherapy, wasn't really doing very much. Attempts have been pursued to sort of escalate dose, which surprisingly backfired. Patients who had a higher dose of radiotherapy did worse. Cetuximab, many attempts were done to try to improve on this. And it seemed that the chemo radiation here would sort of like trigger the antigenic release and perhaps stimulate the immunity. But what is the use of that? Why hasn't it been, worked on? Why hasn't our own body responded? Because of this breaking mechanism of the PD-L1 interaction. And with the use of durvalumab, PD-L1 inhibitor, perhaps releasing this inhibitory cycle, this mimicry that the cancer cell is sort of tricking us into, will somehow enable our own immune system to combat the tumor for us. And this was the basic concept of the Pacific trial. And it took patients with locally advanced unresectable stage 3 non-small cell lung cancer. They had to have received at least 2 cycles of platinum-based concomitant chemoradiotherapy. As you can see here in red, any level of PD-L1 expression was allowed, and maintenance durvalumab was given for a year. And the progression-free survival tripling, 16.8 versus 6 in the preliminary first reports back in 2017, and almost a doubling of the overall survival. And this benefit was seen in all subgroups of all patients. And even at 3 years, we can see here the median overall survival was still not reached with an impressive hazard ratio of 0.68. Even the worst prognosis patients with brain mets seemed to decrease the incidence of a brain relapse. And what was the latest? The latest was 4-year survival update last ESMO. And we can see finally 47.5 a median overall survival versus 29.1. Massive difference. Also still preserved progression-free survival, hazard ratio 0.55. And FDA gave it an all-through approval for durvalumab maintenance or consolidation. However, the EMA requested sort of a post hoc analysis to be performed, and it found those patients that did not have a PD-L1 in excess of 1% did not do so well. However, I remind you, this was not a prerequisite of the trial. Any PD-L1 was admitted into the trial, but this is how the EMA regulatory authority, I guess, gave it its approval. Now let's shift to stage 4. You can stand all alone monotherapy here, just like a proud Freddie Mercury, or you can be in combo as a non-chemo-based or a chemo-based. And the randomized control trials for monotherapy, which I'll try to go through swiftly, I hope. KEYNOTE-024, KEYNOTE-042, both pembrolizumab trials, EMPOWER 110 with atezolizumab, EMPOWER with an E with cemiplimab, the newcomer on the block, and CheckMate 026 and MYSTIC for nivolumab and durvalumab respectively, which were negative trials, but I'll just try to mention them quickly. Now, this was the first, promising breakthrough trial that caused a big paradigm shift, the KEYNOTE-024, which had a tumor proportional score of more than 50% for PD-L1. So we were selecting no EGFR ALK mutations were allowed, no untreated CNS mets, or any active autoimmune disease. And again, pembrolizumab versus the standard of care chemotherapy. And here we can see the impressive hazard ratio, progression-free survival, 0.54. And in the first results also of overall survival, we can see that it was median overall survival was not reached, and most of the hazard ratios are in the range of 0.6 in most of the trials. And here we can see that the median overall survival with later reports hazard ratio was still preserved at 0.63. And really, it was quite a paradigm shift. And this is the 5-year update of overall survival reported by Professor Bramer last ESMO. And we can see here that still the hazard ratio is preserved, and 0.62 and 26.3 months versus 13.4 months. This is even despite that 66% of the patients did cross over or receive further immunotherapy. So really, it was something worth it to see a doubling in the overall survival, even despite this high 66% crossover, and it was quite a tolerable treatment. Now let's shift to KEYNOTE-042. And here, the PD-L1 level was set at 1%. Again, pembro versus chemo. And yes, it was positive. The hazard ratio was 0.81, not as impressive as the final, KEYNOTE-024 was 0.62, but it was mostly pushed by the patients having a more than 50% score. And this is in line with previous, that PD-L1 90 to 100% versus even 50 to 90% seem to do better. And this interesting analysis by Professor Roy Hurst, and he sort of had a retrospective analysis of tumor mutational burden in patients that are PD-L1 in excess of 1% from the KEYNOTE-010 and KEYNOTE-042. And it found that if you're PD-L1 positive with a higher tumor mutational burden, as in this case, 175 mutation per exome, it seemed to confer that you will benefit more with the use of immunotherapy, in this case, pembrolizumab. The second agent we will be talking about as monotherapy is atezolizumab in the IMpower 110, again, atezolizumab versus platinum, and no EGFR or ALK were admitted in this as in the previous, keynote trials. And here we see a positive overall survival, almost 7-month benefit, and hazard ratio close to the 0.6, 0.59. But this was in the high expressors, and in the low TC123 or IC123, we did not see this overall survival benefit. In fact, this was interesting. This analysis was performed using different assays for measuring immunohistochem, PD-L1 expression, SP142, 22C3, and SP263, and they all seem to show the positive benefit that we would see with these agents, and yet the lack of benefit with immunotherapy in the low expressors. Now, this is the EMpower with an E, cemiplimab, which was approved in squamous cell carcinoma. And just again, this is, I guess you could say it is a Me Too trial. Again, PD-L1 expression over 50%, but it has been praised that it had a more, worldly expression, real world, more regions of the world were expressed, and is more a high percentage of patients which clinically stable CNS metastasis, which is again a reflection of what we do see in the clinic. And even despite the high crossover, 74% crossover rate, and 2 analyses we have for overall survival still in an intent to treat the whole population, and later on a regulatory, revision of the PD-L1 test was performed, still hazard ratio 0.68 and 0.57 were observed. Now for Checkmate 026, nivolumab versus chemotherapy. And here, in patients having more than 5%, unfortunately, it did not show any benefit in overall survival, as you can see by the overlapping of the curves. Now, this is the MYSTIC trial, I guess several stages, and we'll be discussing here, as I'm still discussing monotherapy, are durvalumab versus chemotherapy. And here the primary endpoint, unfortunately, no significant improvement with durvalumab versus chemotherapy. And they tried to Professor Solange Peters tried to reason with tumor mutation burden, yet as you can see, I've highlighted here in yellow, no benefit, crossing the boundary of 1E, a trend, yes, but no benefit. And same, no benefit also. It was an exploratory analysis, but yet it did not find any benefit for single agent durvalumab. Now, all the guidelines, I guess, would agree with this, but I've just chosen the NCCN because they are most, frequently updated. I mean, this version 4 of the NCCN 2021, and it's just been updated on the 3rd of March. So we can see I've highlighted here pembrolizumab, atezolizumab, and cemiplimab has been added also for squamous and non-squamous. Now we're shifting to our combos, and now we're going to basically talk about non-chemo, what other than IO-IO. And the first, our favorite or most famous duet is nivolumab and ipilimumab, and I'll be discussing Checkmate 227 Part 1A, in which patients with over 1% PD-L1 expression were represented in this trial. Over 1,000 patients were represented. And yes, with flying colors, Nivo came through, 0.79 hazard ratio for overall survival, and almost a 2-month benefit, and yet again 0.82 positive hazard ratio progression-free survival. And even with the 3-year update by Professor Ramalingam, even despite a 76% crossover to subsequent immunotherapy, yet still preserving this hazard ratio and positive signal, especially with the doublet, and not for Nivo as a single agent. And even, of course, this difference is more pronounced when you get a tighter hazard ratio 0.7 and a higher median overall survival if you select patients having PD-L1 higher than 50%. Now, coming to the MYSTIC study, this is another duet, durvalumab and tremelimumab. And unfortunately, again, no signal here for the duet versus chemotherapy. try to, reason again with the point I made earlier about tumor mutational burden. There seemed to be a higher response rate here. It was found in progression-free survival, yes, here. As you can see, 0.53 hazard ratio. And it was also seen here if you had a higher tumor mutation burden, more than 20 mutations per megabase, it was still seen here also. But again, this was an exploratory analysis. It was not the primary intent of the trial. Now coming to our second combination with chemotherapy, you can either have a chemo with a single IO, you can have a doublet IO with the chemo, you can add a targeted agent. Of course, many agents are being explored now. So far, what we have is VEGF, and perhaps some alternative approaches playing around with your chemo. Perhaps less chemo will take you a bit further. And here's the first report by Professor Lena Gandhi, Keynote 189, pembrolizumab with pemetrexed, cisplatin or carboplatin, and really positive signals, halving of the incidence of progression and survival, to cut it short, really, were very durable. And its counterpart, squamous non-small, is Keynote 407, again with the corresponding pembro carboplatin, paclitaxel for squamous, favorite chemotherapies that we like to use with squamous. And again, still we see a positive hazard ratio of 0.64. In fact, this interesting analysis done by Professor Pazaris collected the predecessor 189-021G and 189 and 407, and even patients who had a expression less than 1% still had a positive hazard ratio. So it seemed that giving chemotherapy gave that extra push to pembrolizumab in the not so high expressors of PD-L1. Now to IMpower130 atezolizumab with carboplatin, nab-paclitaxel in non-squamous, non-small. And the interesting thing about these trials is that EGFR mutated or aberrations were allowed if they had progressed on their targeted therapy or were intolerable to them. And positive hazard ratio was seen 0.79 and an improvement almost 5 months in the median overall survival. IMpower131 was in the squamous non-small cell lung cancers with atezolizumab, carboplatin, and paclitaxel or nab-paclitaxel. Positive signal in the progression-free survivors I've highlighted here in red, not seen in overall survival, unfortunately. IMpower132, again, atezolizumab with carboplatin and pemetrexed. Pemetrexed for non-squamous, expected to do well, yes? Unfortunately, no. Did not meet the mark for an improvement, hazard ratio 0.86, a trend, but as you can see, the curves are very close and crossing the boundary of 1. Now, maybe we can give it that extra push with the addition of bevacizumab. And here we see carb-paclitaxel with bevacizumab. And again, EGFR and ALK altered patients alterations were allowed in these patients. This analysis show you for the wild type, we have a hazard ratio of 0.78 and a positive signal, definitely. 19.2 months versus 14.7 months. Now we come to Checkmate 227 again, Nivu and Ipi with nivolumab with chemotherapy, because we are testing patients with PD-L1 expression less than 1% versus our standard of care chemotherapy. And yes, the signal was there. We were expecting chemotherapy with nivolumab to give it that extra push, but not the case. As you can see here, the hazard ratio did not really, it was a trend, but still the duet of IO-IO. So I guess it's a good regimen you could consider if your patient has any sort of contraindication to receiving chemotherapy. And hence the approval, the FDA approved it, the nivolumab and ipilimumab for patients who have only expression over 1%. Now, this is a Canadian CCTG group, BR34 durvalumab tremelimab with chemotherapy versus the immunotherapy alone. And unfortunately, as we see here, no overall survival benefit. Now, this is the last trial we'll be discussing, Checkmate 9LA. It is nivolumab, ipilimumab, our favorite, sort of duet, with chemotherapy. But interestingly, only 2 cycles of chemotherapy were given in this trial, and they did quite well. And even patients having all PD-L1, all comers were taken. And despite that, we have the usual hazard ratio in the range of 0.66 and almost 20% or more improvement in overall survival. So just this is a slide of Dr. Martin Reck, of course, and we see that really you can consider IO monotherapy if with pembrolizumab or atezolizumab if more than 50%, and as this was done December 2020, now you can add to this subset cemiplimab as well, as we've just seen from the guidelines page. You can consider adding IO and chemo here with atezolizumab or pembrolizumab. And for all comers also, you can use IO with chemo, as in CheckMate 9LA, with an abbreviated course of chemotherapy. So coming back to our first question, does first-line IO, first-line non-small, does it fit all? We're trying to make it fit, you know. Of course, great work is being done by great, you know, leaders in the field with the Pioneer study, I guess, looking at different, trying to form a map, trying the National Lung Matrix. Many, you know, people are trying to, a lot of work is underway, trying to form an immunogram, sort of to see which patients will benefit from an IO as a mono, as a doublet, as a chemo, as coupled with another TKI, with another agent, perhaps. And we know that essentially EGFR and ALK were usually excluded from most trials except for the IMPOWER atezolizumab trials, but because we know these patients do not respond that well to these treatments. And even if they do take them, sort of they have more severe autoimmune adverse events. And the agent that did seem to have initial promise was the IMPOWER 150 regimen with bevacizumab. As you can see, of the 800 patients, only 100 and so patients actually did harbor the EGFR or ALK alterations. So we could even comment on them anyway. So they did show a positive progression-free survival overall 0.59 hazard ratio. Unfortunately, in the last ESMO, it was reported that there was a trend for improved survival, but it did not reach statistical, you know, significance. So it may be a regimen to contemplate if all else fails. And what about autoimmune disease? I mean, these patients were always excluded, but actually real-world data, mostly a lot of retrospective analysis, and this is the largest of which, a well-kept database in the US, 2,000 patients. Of these patients, 500 or so patients had autoimmune diseases. And as you can see, the adverse events, as long as these patients were sort of, you know, not stable or not on active therapy, or perhaps not on any serious neurological autoimmune disease, they tolerated treatment quite well, and the outcomes were quite similar to patients who did not have any autoimmune diseases. So the pool is enlarging, it is accommodating more patients. So in the end, a conclusion, stage 3 concomitant chemoradiotherapy followed by consolidation durvalumab is our new standard of care. When we come to newly diagnosed stage 4, when we've excluded all our targetable mutations or perhaps patients that require just best supportive care, we can sort of, the best imperfect biomarker that we do have is PD-L1. If you have PD-L1 high expressors, you can give monotherapy with the agents that we mentioned. If we have PD-L1 low, we can add the doublet with chemotherapy, atezo and chemotherapy, or bevacizumab, and perhaps even, as we've just seen, even if you are a negative expressor, you can use the CheckMate 9LA. So does it fit all? Not everybody is the same. We all have different fingerprints. We all have different ethnicities, different backgrounds. So why should we expect immunotherapy to fit the same? But we'll keep trying, we'll keep adjusting. We'll get through it. After all, when we do target our cancer, we target it with exact precision. We plan our radiotherapy with precision. We accommodate our chemotherapy with precision. And so immunotherapy, hopefully, we will reach that required precision to give the best results to our patients. And thank you so much for your attention.
Thank you, Dr. May, for the excellent presentation as usual. We'll keep the discussion about lung cancer management after the end of the 3 sessions. Now we'll go for the second line setting. So let me introduce Dr. Ahmed Saeed Abdel Mittal. Dr. Ahmed Saeed is a consultant clinical oncology at Ain Shams University. Dr. Ahmed will present for us IO in second line therapy in lung cancer, non-small cell lung cancer. Dr. Ahmed, please. And please, I ask the attendees to send their questions in the Q&A sections, and we'll answer after the lung cancer session completely. Dr. Ahmed, you can start.
Thank you, Dr. Ahmed Gaballah, for this nice introduction and for inviting me to share with you this talk in EMOG. It made it easy with my colleague, Professor May, to start with the first line, then to continue with the second line. So this is my disclosures. So the evolution of second line therapy in non-small cell lung cancer, improvement in the first line setting, made patient easily to have a longer disease-free survival with likelihood of having a good performance status at relapse. So this improvement means patient will likely benefit from further management upon relapse, establishing the role of second-line chemotherapy for more patients. Docetaxel was the first agent approved by the FDA for second-line therapy, then followed by a targeted therapy option. The estimated 5-year rate for patients with metastatic lung cancer based on data from 2008 to 2015 was approximately 5%. So long-term overall survival benefit with immunotherapy was first shown in melanoma in a large pooled population of patients with follow-up of about 10 years. Agent targeting PD-1 and PD-L1 axis have transformed the management of non-small cell lung cancer and emerged as a new standard of care for previously treated advanced non-small cell lung cancer as well as first-line setting. So the history of patient outcome in non-small cell lung cancer, we can see that over the last 3 decades, 1-year survival rate increased from 35% for patients diagnosed from 1975 to 1979. For patients with advanced non-small cell lung cancer, current outcome for the use of systemic therapy are poor, with an overall response rate of 25 to 35% in the first line setting, with time to progression 4 to 6 months and immediate survival of 8 to 10 months, with 1-year survival of 30 to 40% and 2-year survival of 10 to 15%. We all know that lung cancer also depends on the stage on the diagnosis, with a 5-year survival in the distant metastatic setting with 4.5%. So evolution of survival outcome in second line setting came, as we can see here, from docetaxel in 1992, with the introduction also of erlotinib and pemetrexed 2004. Then came ramucirumab, docetaxel, nandanib, and docetaxel for non-squamous, then pembrolizumab in 2015, and first immunotherapy was approved in 2015, and nivolumab in squamous and non-squamous non-small cell lung cancer in the second line setting, to be followed by atezolizumab and also pembrolizumab in the same year with nivo. And median overall survival improved with each introduction of this agent, and immuno-oncology therapy replaced docetaxel as the preferred second-line therapy based on improved overall survival, high response rate, longer duration of response, and fewer adverse events compared with docetaxel. So as we see here, we have the platinum doublets, then the EGFR mutation with the start of gefitinib versus carboplatin plus paclitaxel, then alectinib for the ALK-positive population, then the introduction of nivo as the first approved molecule for non-small cell lung cancer in the second-line setting. So this is the history of checkpoint inhibitors that we have till now in the second-line setting. As we mentioned before, nivolumab approved in the US here for squamous, then followed by the non-squamous, pembrolizumab for the non-squamous second-line setting for PD-L1 more than one, then to be followed in Japan, Europe, as we see lately atezolizumab in Europe and United States. So we have these three molecules approved as the immuno-oncology therapies for the treatment of metastatic non-small cell lung cancer. As you can see here, nivolumab for metastatic non-small cell lung cancer with progression of or after platinum-based chemotherapy. Also, we can tackle patients with EGFR ALK after progression on FDA-approved therapy for this abrasion that comes for all in the US population. We can complementary diagnosis with PD-L1 immunohistochemistry. Not required for use for nivolumab. In Europe, also locally advanced or metastatic non-small cell lung cancer after prior chemotherapy. And for the pembro for metastatic non-small cell lung cancer with TPS and PD-L1 more than one, here we should do the immunohistochemistry for PD-L1, also approved in Europe for locally advanced or metastatic non-small cell lung cancer expressing PD-L1 more than one after prior chemotherapy. And lately, atezolizumab for metastatic non-small cell lung cancer with progression on or after platinum-based chemotherapy in the United States, also for EGFR ALK positive patient after receiving FDA-approved therapy and progression on it. So here, complementary diagnostic is Ventana, but it's also not required for the second-line setting, as can be given to all comers, as we can see, and also approved for Europe for the locally advanced or metastatic non-small cell lung cancer after prior chemotherapy. So we have the nivolumab clinical trials. First of all came the Checkmate 03, and it was exploring nivolumab in different dosing schedule. As you can see, the eligibility criteria: advanced non-small cell lung cancer, equal performance status 0 to 1, one or more line of prior systemic therapy were allowed. As the primary endpoint was safety and tolerability and anti-tumor activity in the second objective endpoint, with exploratory objective as overall survival and PD-L1 analysis. We can see here a 6-year overall survival with nivolumab in this trial, with a median overall survival of 9.9. And you see here the CTs of 9-year survival of nivolumab on the Checkmate 03 trial. And came after that a 2 randomized phase 3 trial with a Checkmate 057 for patients with metastatic non-small cell lung cancer on the second-line setting, randomized for nivolumab or docetaxel with non-squamous histology, and Checkmate 017 study for the squamous histology, also randomized for nivolumab or docetaxel. The primary endpoint were for both the overall survival and secondary endpoint include progression-free survival, objective response rate, and durations of response. So nivolumab achieved a significant higher overall survival versus chemotherapy for both squamous and non-squamous non-small cell lung cancer after 3-year follow-up. We can see here on the left the Checkmate 017 for the squamous non-small cell lung cancer with improvement in the overall survival against docetaxel. And here is the Checkmate 057 for the non-squamous histology, and also nivolumab induced an overall survival benefit versus docetaxel used with a good hazard ratio of 0.62 in the squamous and 0.73 in the non-squamous histology. You can see here in the Checkmate 057 for the non-squamous histology, the overall survival, the median overall survival reaches around 12 months in the nivolumab arm versus almost 9 months in the docetaxel arm, and this maintained all over in each specific point survival at 12, 24, and 36 months. There was almost difference of around 10% in the number of patients surviving in each point versus docetaxel. So for previously metastatic non-small cell lung cancer, nivolumab demonstrated longer median overall survival of 17.1 months versus 9 months of chemotherapy for patients expressing PD-L1 at all levels, more than 1 for 3 years follow-up. And here is, as we can see, even in the less than 1%, we can see 10.4 months versus 10.1, and the intent to treat population here is 12.2 months versus 9.4 months, and more than 1%, we have 17.1 versus 9 months with a gain of 8.1 months in the overall survival. And this increases as the PD-L1 increase, as we can see with exploratory analysis for patients more than 50 with 19.4 months versus 6.9 months with a hazard ratio of 0.32. As we see from the pooled analysis of CheckMate 017 and 057 pooled analysis, the median overall survival per PD-L1 expression level all favors nivolumab rather than docetaxel, with a hazard ratio of 0.78 to 4.2 of 0.42, favoring nivolumab rather than docetaxel in all subgroup of PD-L1, either in the low, more than 1, 5, or more than 10, or more than 50, all on the intent to treat population. You can see here 11.1 months versus 8.1 months. So the landmark analysis for overall survival by response to category status at 6 months in the CheckMate 017 and 057, we can see here that after the response, after 6 months, we stratified the patient according to the response criteria, and overall survival according to this, we can have that the median overall survival for complete response and partial response is not reached, and stable disease is 16.1, and for the progressing is 9.1 months. In the docetaxel arm, the median overall survival for the complete response or the partial response are 17.1, and that for the stable disease are 8, and for the progressing patient are 4.8 months. And said clearly the huge difference, and this maintained overall survival benefit for the CR and PR group of patients at as they go with time. The benefit of overall survival is still maintained. That you can see here the sloping curve of docetaxel. So overall survival also for previously treated metastatic squamous and non-squamous cell at 5 years follow-up, we can see here in the nivolumab arm, it is 11.1 months, and in the docetaxel, 8.1 months, with a hazard ratio of 0.68. As you can see here, the difference at each step, each landmark for overall survival at 12, 24, 30, 48, and at 5 years, we have more than 10% increment in the overall survival versus docetaxel. So overall survival is still significantly higher with nivolumab versus chemotherapy over 5-year follow-up in the combined pool analysis. And by PD-L1 status, also the overall survival favors the nivolumab versus chemotherapy arm. As you can see here, and even for PD-L1 less than 1, the median overall survival is 9.7 in the nivo arm versus 7.8, with a gaining of 2 months in the median overall survival for this patient. And still, we can see the difference is still maintained all over the time goes by at 12, 24, 38, 48, and 60 months. Regarding the progression-free and duration of response with nivolumab versus docetaxel, we can find that the PFS, even somehow in the nivolumab, is less in the median, but as you can see with the curve, as the patients maintain their progression-free survival, the curve is plateauing and gaining progression-free survival at 5 years, 8% with 0% in the docetaxel arm. And for the duration of response, we all know that most of the immunotherapeutic molecules have a median duration of response higher than that of the chemotherapy. And this is a special characteristic of the immuno-oncology versus conventional chemotherapy. You can find it here as 19.8, 19.9 versus 5.6 in the docetaxel arm. So the overall response also was 19.7 versus 11.2 in the docetaxel arm favoring nivolumab. Here, what I'm talking about, maintaining progression-free. So the patient, as have 2-year progression-free survival, they will have 76% chance of still progression-free at 3 years, and 68% at the 4th year, and 60% to be progression-free at the 5-year. And whenever the patient is still having non-progressive disease with time, the chance of having this stable disease or maintaining this response without progression increases. As the 4-year progression-free survival, 88 of them will be alive at 5 years. For the docetaxel arm, you can see that 4 and 1 patient had PFS of 2 and 3 years, but none of them survived beyond or equal to 5 years in this pooled analysis. So long-term survival outcome with nivolumab in patients with previously treated advanced non-small cell lung cancer and the improvement of early disease control and response. We have many pooled analyses, the pooled analysis of all patients treated with nivolumab for advanced non-small cell lung cancer for the 2nd line, and the pooled analysis of CheckMate 017 and 057 for all patients randomized to nivolumab versus docetaxel. So the overall survival for all the nivolumab treated population, you can see a median overall survival of 10.3. And remember, this all came from the pooled analysis for phase 2 and phase 3 trial on different histologies. And you can see a 46% overall survival at 1 year and 26 at 2 years. And we still at 4 years having 14% overall survival. As regards the safety, nivolumab was tolerable with fewer side effects than conventional chemotherapy. We can see here the distribution of adverse events versus conventional chemotherapy. We can see the treatment is tolerable with any grade toxicity, 69%, with grade 3 and 4, 10%, rather than 88% of any grade and 54% of grade 3 and 4 in the docetaxel arm. So the summary of nivolumab with the CheckMate 017 and 057 are the first randomized phase 3 trials to report 5-year outcome for PD-1 inhibitor in patients with previously treated advanced non-small cell lung cancer. The 5 years pooled overall survival 13.4 with nivolumab versus 2.6% with docetaxel. We have 5-fold increase, and the 5 years pooled progression-free survival rate is 8% with nivolumab versus 0% in the docetaxel arm. This means that your number of patients are increasingly having progression-free or overall survival with difference to docetaxel. You have a lesser number of patients that will have a progression-free or overall survival with time. Patients without disease progression at 2 and 3 years after treatment with nivolumab had 60 and 78 chances of remaining progression-free at 5 years. There is no baseline clinical or tumor characteristic clearly distinguish long-term survivor receiving nivolumab. At 5 years, 10% of nivolumab survivors were off study drug after 8 to 43 months of treatment, had not progressed and had not received subsequent therapy. With 5-year minimum follow-up, no new safety signal were identified for nivolumab. There was no evidence of late onset grade 3 or 4 selected adverse events. And coming to the second molecule, pembrolizumab, we have the KEYNOTE-010 randomized trial for pembrolizumab versus docetaxel in the second-line setting non-small cell lung cancer. To all the histology, we have 2 doses of pembrolizumab, the 2 milligram per kg every 3 weeks, and pembro 10 milligram per kg every 3 weeks for 24 months, and the docetaxel for 75 milligram per meter square every 3 weeks until disease progression. The primary endpoints were progression-free and overall survival, and secondary endpoint were overall response, duration of response, and safety. But remember, pembrolizumab was given in patients having PD-L1 status of more than or equal to 1, not the negative ones. So the updated overall survival, we can find a comparable median overall survival for the 10 and 2 milligram per kg with 10.5 and 13.6 months. And in the docetaxel, it is coming with the standards that we find from the previous trial at 8.6 months. And 18 months survival rate is 37 and 43 in the pembrolizumab different arm and 24 in the docetaxel arm. For PD-L1 status more than 50 population, you can find the huge difference, and the median overall survival 16.9 versus 8.2 months, and 3 years overall survival of 35% versus 13%, with hazard ratio of 0.53 and significant p-value. While in the PD-L1 more than 1 in the intent to treat population, we find the median overall survival is 11.8 versus 8.4 months in the docetaxel arm, and 3 years overall survival 23 versus 11, with hazard ratio of 0.69 with statistically significant p-value. And as regards the progression-free, for those having PD-L1 more than or equal to 50, the progression-free was 52 for pembro versus 4.1 for the docetaxel arm, while that for the intent to treat or more than 1, as you see, the progression-free survival was almost the same in both. And for the safety, we can find here it is consistent with that we can find with immunotherapy versus conventional chemotherapy, with any grade toxicity of 63% and grade 3 to 5, 13%, while we can find in the docetaxel arm 81% any grade and 35% of severe grade 3 to 5 toxicity. And coming to atezolizumab, after a phase 2 popular came the OP3 in a phase 3 trial, atezolizumab versus docetaxel in the non-small cell lung cancer. Patients were randomized to atezolizumab 1,200 milligram every 3 weeks versus docetaxel 75 milligram per meter square every 3 weeks until disease progression or loss of clinical benefit. And patient population was locally advanced or metastatic non-small cell lung cancer, 1 to prior lines of chemotherapy, including 1 line of platinum chemo. All PD-L1 status were allowed. The primary endpoint is overall survival in the intent to treat population and overall survival in patients with more than 1% PD-L1 expression in the different group. Secondary endpoint as overall PFS and overall response, PFS and duration of response, and safety, of course. Let us comment that atezolizumab trials have a different scoring system for PD-L1. They score it on the tumor cells or the tumor infiltrating immune cells and giving different scores that we can see here that tumor score or immune score are grouped as follows. High expressor. في حاجة بصوت؟
لا time.
Yeah, I'm about to finish, don't worry.
Okay.
So overall survival intent to treat, as we find, atezolizumab came with after 19 months follow-up landmark overall survival 55% versus 4.1, and at 18 months, 40% versus 27, with a median overall survival of 13.8 versus 9.6 months, with a good hazard ratio and significant p-value. As you can see it here from the 2-year update, still the significant overall survival improvement for atezo versus docetaxel is maintained. And also for the different grouping of patients according to the PD-L1 status, all favor atezo rather than docetaxel. For the PFS, it is almost like Nivo with a PFS of 2.8 versus 4 in the docetaxel arm, but we can see here after the initial, the patient, as long as they maintain their non-progressive state, they will maintain it longer than the conventional chemotherapy, as we all know. And with a good tolerability, as the same with, that we can find in immunotherapy rather than conventional chemotherapy, with fewer immune-related adverse events. So the clinical benefit of IO across PD-L1 expression in second-line setting, we can see it in the checkmate pool analysis. All favor nivolumab rather than docetaxel. In the OAK, it favors atezo versus docetaxel, and in the keynote, it favors pembro rather than docetaxel. But remember, in the pembro, the negative or less than 1 PD-L1 expression were not allowed to enter in the study. So overall survival benefits were observed across the PD-L1 spectrum, including less than 1 PD-L1 expression with enhanced benefit with increasing PD-L1 expression. This is a cross-trial comparison, but we allow to learn how the immunotherapy benefit in the overall survival is maintained on most of the trials for the molecule approved. So evolving treatment landscape in the first line, we have now immunotherapy in the first line, and the second line setting will have some IO experienced population rather than progression after disease control or primary resistance with no response. So for the first line treatment, patient may have monotherapy IO or IO with chemo or chemo. For those receiving mono, the approved approach for them is platinum doublet. Also for those receiving combo, we can give docetaxel, 90-datinib, or combination with ramucirumab or clinical trial. But if they received only chemo, we can proceed to IO regimen as we explained here. So we have a selected ongoing trials for IO experienced second line. We hope to have a different combination of IO in the IO experienced non-small cell lung cancer. So from the NCCN guidelines, we can find here for systemic therapy for advanced or metastatic disease in the subsequent systemic therapy for adeno large cell non-small cell lung cancer, if they don't have previous exposure to IO, category 1, Nivo, Pembro, and atezolizumab. For the squamous, also Nivo, we have Pembro, we have atezolizumab in the non-IO exposed. We have other recommended regimen for the no previous or previously exposed docetaxel, pemetrexed, and ramucirumab docetaxel. So to conclude, we now have established role for IO in second-line non-small cell lung cancer with 5-year overall survival data in second-line therapy. Clinicians have to stick and respect the result of clinical trials in this setting. Continued therapy with checkpoint inhibitor will add on in the term of overall survival. Immunotherapy is a promise that patients are looking forward to, but let's not forget that we still have a long path before curing all patients. Thank you very much.
Thank you, my dear colleague, Dr. Ahmed, for this nice presentation. We have a lot of IO therapy today. We will continue with the IO therapy with our dear colleague, Dr. Ahmed Hassan Abdulaziz. Dr. Ahmed Hassan is a consultant clinical oncology at Ain Shams University. and he is a visiting consultant of clinical oncology at NHS UK. Dr. Ahmed will give us a talk today about IO in small cell lung cancer and mesothelioma to complete the full panel of treating lung cancer with IO. Dr. Ahmed, you can start.
So here, thanks, dear Dr. Gabala, for the invitation. I would like to thank also the EMOG group. Very well conducted agenda over the 2 days. Let me share my slides. Is it visible now?
Yes, Dr. Ahmed. Yes, okay.
Right. So I will be discussing in the next few minutes immunotherapy in small cell lung cancer and mesothelioma. So small cell lung cancer is a subtype of a neuroendocrine tumor, but it lies at the far end, at the aggressive end of the neuroendocrine tumor. It represents 15% of all lung cancers, and it occurs predominantly in smokers, almost always associated with smoking. Small cell lung cancer is distinguished morphologically, biologically, and in terms of prognosis from other lung cancers. It's completely different from non-small cell lung cancer. It has a very high doubling time, very high growth fraction, and tendency to develop metastasis. It's almost always a systemic disease, even if it is discovered at a very early stage when it is still limited. Patients with small cell lung cancer have an adverse prognosis, unfortunately. If they are not treated, survival is usually counted in weeks or even days. So some reports say best supportive care gives patients around 60 to 90 days, less than 3 months sometimes. However, they are very highly responsive to systemic treatment, to chemotherapy. And you can see sometimes dramatic improvement in the scans and the clinical picture of the patient with even 1 cycle of chemotherapy. And this is one of the very few indications when we start systemic treatment, even if the patient is presenting with a poor performance status, that you are confident that this decline in the performance status is related to the disease rather than other background comorbidities. Sometimes we offer non-small cell lung cancer patients chemotherapy when they are inpatients, or occasionally when they are in the ICU. From the time they are diagnosed, the median survival with chemotherapy, as I will show you in a while, ranges from 8 to at best 13 months. Most literature points towards median overall survival of 8 to 10 months. And then less than 5% of those live to see 2 years. And median progression-free survival is between 4 to 6 months, meaning that by the time you finish the 4 or 5 cycles of chemotherapy, you will start already to see disease progression. And unfortunately, for like 4 decades, we haven't seen any advances, any new additions to chemotherapy. So since the 80s, the studies were looking at what is the best platinum to use, what is the best counterpart to add, shall we add a third component, shall we give treatment concurrently or sequentially, shall we offer maintenance treatment after an initial block of chemotherapy? And these movements or these trials, they did not add much really. This is a collection of studies testing several regimens from the 80s down to the 2000s. And what I want to highlight is the median survival figures that you can see here, and they range from 8, 9 to 10, 11 months at best. So there was indeed a need to develop new treatments. There was a need to explore new druggable targets. And rapidly proliferative disease like this definitely has a good ground for research. There's high mutational burden. You always see P53 retinoblastoma mutations and other types of mutations, but efforts have been not very successful until the last couple of years. I'm sure you must have seen this slide in other presentations earlier today or yesterday, but I will show the area of interest with regards to this talk, the small cell lung cancer. As you see, in comparison to other tumor subtypes, it has a high mutational burden. So currently, there are many ongoing studies trying to tackle the BRCA pathway using PARP inhibitors, the DLL3, but for the sake of the context of this event, I will focus only on the frontline immunotherapy treatment. In this regard, we have 3 key studies. We have the IMpower 133, and I'll tell you one thing that is practical, and it will help you to memorize the design of the study from just looking at the name, because I struggled with this for some time. So IMpower is lung, IMbrave is liver, IMpassion is breast. That's easy. If you look at the first digit, 1 is the first line, tells you that this study was designed in the first line. 3 tells you the number of agents used in the investigational arm. So for example, Dr. Ahmed Saeed and Dr. May were talking about IMpower 110. So 110, 1, they used only a single agent, atezolizumab. Here in IMpower 3, they were using 3 agents. That's atezolizumab in addition to carboplatin and etoposide. The third digit tells you if it's non-small or small cell lung cancer. So if it's non-small cell lung cancer, it's 130, for example, or 110. But for small cell lung cancer, like in our case here, it's 3. The third digit is 3. So this can help you or give you a little bit of a background about the study. The other 2 key studies are the Caspian study, the durvalumab, and the Keynote 604, which used pembrolizumab. These are the differences and similarities between the 3 key studies. We have also a 4th study, that's the ECOG 5161, which looked at nivolumab, but this was a phase 2. I'll be focusing mainly on the phase 3 trials. So the 3 studies were phase 3 trials. The Caspian study was an open label. Atezolizumab was a blinded placebo-controlled, as well as the Keynote 604. All of them, they used carboplatin, but not all of them used cisplatin. Prophylactic cranial irradiation was not used in the investigational arm in the Caspian study, but it was left for the treating physician to use if deemed necessary in the other studies. Chemotherapy cycles are 4 cycles, which is the standard. And I'm not sure why many of us here in our local practice in Egypt, we use 6 cycles, because we know that there is very little benefit, if any, from adding 2 extra cycles. However, in some selected patients with high volume of disease that keep on responding, you can consider 2 extra cycles, but the mainstay or the standard of care is 4 cycles of treatment. Caspian allowed for 6 cycles, which is more relevant to what we do here most of the times in Egypt. And then they all offered maintenance immunotherapy after completion of the chemotherapy. Caspian offered durvalumab every 4 weeks. IMpower offered atezolizumab every 3 weeks. And here pembrolizumab in the Keynote study every 3 weeks. Caspian study randomized patients in a 1-to-1 pattern into 3 arms, equally weighted, durvalumab plus tremelimumab plus chemotherapy. And as I said, it's etoposide plus platinum of your choice, cis or carbo. Second line is durvalumab alone and chemotherapy, or the standard treatment, which is etoposide and platinum. Primary endpoint was overall survival. The study looked at 800 patients, but if we are going to compare this study to the other 2 studies, we will be really looking at these 2 arms, the durvalumab chemo versus chemo alone. And for these 2 arms, the study size was 500. So it's almost equivalent to the other 2 studies. So most of the patients were offered 4 cycles, but some patients went on to have 6 cycles. The median total duration of durvalumab was 28 weeks. That's roughly 7 cycles of treatment. The overall survival results showed a clear benefit in favor of immunotherapy. So those receiving durvalumab concurrently with chemo and then maintenance, they showed median overall survival of 13 months versus 10.5 months. and the hazard ratio was 0.75. There was survival benefit was maintained at 1 year, 1 year and a half, and 2 years. And if you look at the subgroups, the benefit was concordant across all subgroups, and even in those showing brain metastasis, they had also some sort of benefit, although the confidence interval was very wide because of the small sample size. So those who had brain metastasis were only 55 in the study. So that's why you can see the confidence interval is spanning over the line of unity. When they looked at the overall survival in those who had brain metastasis and those who did not have brain metastasis, there was an overall survival improvement in both groups. As regards progression-free survival, if you look at the median progression-free survival, you'll find that it is the same, 5 months. But this is the downside of looking at one point. It's always better to look at the curves or the hazard ratio. So median progression-free survival is a point where 50% of the patient has progressed. So at 5 months, 50% of the patients have progressed. But those who have not progressed, the other 50%, they started to separate after that. So if you look at the time intervals down the line, you'll find that 12 months, 17.9% did not progress versus 5%. At 2 years, 11% did not progress versus 2.9%. So those long-term responders are the ones which demonstrated the maximum benefit in terms of disease control and survival. What about response rates? Well, response rates in multiple clinical trials utilizing chemotherapy alone was around 60%. Adding durvalumab improved it by around 10%, reaching almost 70%. And as I just mentioned, those who respond beyond the median progression-free survival, that's the second half of the curve, they were able to show maintained long-term responses. As far as side effects is concerned, there wasn't much in the way of toxicity. Safety summary did not bring any signals of concern, and side effects, particularly grade 3 or 4, which are more important, they were almost equal in the two study arms. So the advantages of the Caspian study is that it ticked the overall survival, which is the primary endpoint. So there was a clear improvement with a hazard ratio of 0.75. There were no concerns in terms of toxicity. One of the advantages of the study is that give you flexibility to choose platinum of your choice. It gives you the liberty to go beyond 4 cycles. But the disadvantages is it did not offer patients with in the immunotherapy arm or the physicians the liberty to give prophylactic cranial irradiation, which is almost a standard of care in most centers across the world. The second study is the Empower 133. Almost a similar study, almost a similar design, except that it only randomized patients into 2 arms rather than 3 arms. Patients were distributed equally between the 2 arms. So atezolizumab with carbo or etoposide, so no cisplatin, where Americans tend to use carboplatin and etoposide in small cell lung cancer. And we know that there isn't much of a difference in this tumor setting between cis and carbo anyway. Versus the standard arm, carboplatin and etoposide. The co-primary endpoints were overall survival and progression-free survival. Almost similar pattern of curves, improvement in overall survival. Again, the standard arm was 10 months, adding immunotherapy, in this case, atezolizumab, it improved by 2 months. Hazard ratio, almost identical, 0.76. Progression-free survival, again, similar results to Caspian study, 22 versus 30% at 6 months, and 5.4 versus 12% at 1 year. Response rate this time is different than the Caspian study, so there wasn't much of a difference in terms of response rates between chemotherapy and atezolizumab. This slide compares, just puts in front of your eye the two studies, the Caspian and the IMpower 133. So you have identical hazard ratio, and you have similar amplitude of benefit in terms of overall survival. That's why if you look at the NCCN guidelines, you'll find both agents mentioned, but the difference is that you can combine durvalumab with cisplatin, but you cannot combine atezolizumab with cisplatin because of the design of the study. What about the pembrolizumab? Well, in the proof of concept study, the phase 2 study Keynote 158, which is a basket study, or which had so many tumors, there were signals of activity. We've seen good response rates. We've seen good progression-free survival and overall survival. That's why it was pushed forward to the phase 3 studies. And in the Keynote 604, they conducted a blinded randomized study, etoposide platinum in combination with pembro versus standard arm of etoposide and platinum. Progression-free survival, again, similar to the previous two studies, hazard ratio 0.73, and improvement and an improvement in the long-term responders. So you can look at the 12 months point, you find a significant difference. But if you look at the median progression-free survival, again, you will notice the same pattern, no difference between the two arms. As regards overall survival, and this is very important to notice because this is different than the previous two studies, the study group predefined a statistically significant cutoff point of p-value 0.12, and they were not able to fulfill this in the study. So for overall survival, the p-value was 0.16, which is higher than the predefined cutoff. So we cannot tell for sure that overall survival improvement can be attained with pembrolizumab as it was with the other two molecules. Keynote 604 conclusions. These were the conclusions given by the investigators in the last ASCO. They said that they were able to prove significant improvement in the progression-free survival, but they were not able to demonstrate this in terms of overall survival because of the p-value. However, there were durable responses seen in approximately 20% of patients, no safety concerns, and the data is in keeping with the other two studies in terms of response rates and improvement in the progression-free survival. So this slide puts the three trials together, and as you can see, the confidence interval for the IMpower and the Caspian studies are quite away from the line of indifference. However, for the Caspian, the durvalumab and tremelimumab, as well as the Keynote, it's approaching the line of indifference. Is there any role for immunotherapy in the limited stage? Well, this has been investigated in the Adriatic study. In a nutshell, this study is almost the same as the Caspian study in the non-small cell lung cancer. So here you give concurrent chemoradiotherapy as per standard, and after you finish your standard treatment, then you give maintenance durvalumab afterwards, or durvalumab and tremelimumab. It would be interesting to look at the results when they are here. The second part of my talk is regarding mesothelioma. And mesothelioma is surprised. This is because of course, of asbestos, as you all know. And to my surprise, asbestos looks beautiful and white. I thought I had a picture in my mind that it looks black and not and quite scary, but it looks very nice actually, but it's quite nasty in terms of what it can do to your lung. So in mesothelioma, many questions remain unanswered. Shall we use chemotherapy or chemotherapy and radio, or trimodality, surgery, chemo and radio, or bimodality? We're not sure. We don't have quite good evidence and the best sequence of treatment. We don't have even the best, we don't have good evidence on what is the best regimens to use, what is the best surgical approach to use, what is the best radiotherapy protocol to use. So there's very little well-conducted data in this tumor setting. And it's not surprising why we have limited information or limited interest in this disease, because it's a disease of the poor countries, because in the developed countries, the rates of mesothelioma are declining quickly. So here in the UK, for example, the incidence was rising from the 60s when they were using asbestos until it reached a peak in 2010. And then it started declining quickly from 2010. So researchers and pharmaceutical industry are not really very enthusiastic about conducting clinical research here, because they know that in the West, this disease is going to disappear over the next few decades. So we know in mesothelioma that the standard of care is cisplatin and Pemetrexed. We know this from the Emphasis 3 trial, which showed a 3 months improvement in survival in comparison to cisplatin. But since then, there hasn't been much of a progress, really. In 2015, the MAPS group, they added bevacizumab. They elicited an improvement of 2 months in progression-free survival and almost 3 months in overall survival. However, other groups, when they replicated the same study, but with cisplatin and gemcitabine, they were not able to replicate the same superiority. So we have some studies indicating improved outcomes with Avastin. Other studies did not. Again, mesothelioma is a fertile soil for research, and it has many targets that can be druggable or can be potential targets for research. But as I said, research is very limited in this tumor setting. And we have small studies, mainly in the phase 2 study, mainly phase 2 rather than phase 3. For example, here is a single agent second line tremelimumab study, didn't show much of improvement. And then we had combination immunotherapies, the Australian study, which is phase 2 single arm, included only 54 patients. The initial results were promising, showing a 6 months progression-free survival, 57%. But these are phase 2 studies, limited in number, so it will not give you good data that will convince you to change your practice. Again, we have another combination in the first line, immuno this time, which is the Checkmate 743, nivolumab with ipilimumab versus chemotherapy. And we are awaiting the results of this one. In the second line, we have the MAPS-2 study. They're comparing nivolumab versus nivolumab plus ipilimumab after failure of chemotherapy. So these are all, as I said, limited studies, but hopefully they will add something to our armamentarium, which is already limited. So my conclusions for the mesothelioma part is that platinum-based chemotherapy remains the mainstay of treatment. There are some encouraging results from the small phase 2 studies. We will still await the final results of these studies. And more importantly, and this does apply on not only my talk, but all of the talks in the EMOG event, is that hopefully we will have better access for our patients for these very effective agents throughout multiple tumor subsites. Thank you very much for your listening.
Thank you, Dr. Ahmed. I know it is difficult to talk at the end of the EMOG meeting, but I want to tell you that we have 110 attendees was watching you, so don't worry, people are still like,
they really like you, and they really like science, because they're still holding on Friday evening.
After 3 hours of presentations, continuous presentation, continuous science, and they are still coping with us. So now the floor is open for any question and discussion about the management of IO therapy in lung cancer, whether non-small, small cell, and mesothelioma. I think our great speakers are still with us, Dr. Ahmed Hassan, Dr. Ahmed Saeed, and Dr. Mahmoud. So if any one of the attendees want to address them with any question, they are welcome. And if they don't, I think you can discuss together if you have any question to to the faculty. Actually, I'm receiving from my coordinator that the attendees didn't send any questions for us.
I hope they're not asleep by now.
Yeah. So let's move on because we still have 2 more talks. After all these talks about the IO in cancer management and solid malignancies, I think we should pay for the cost. The cost for this is the toxicity. And allow me to present the management of toxicity during IO therapy. I hope I finish this presentation soon to go to sleep. You see my screen now?
Yes, Dr.
Inshallah, I'll talk with you today about the managing toxicity, the cost we should pay during the IO therapy. Actually, I adopted this picture from the New England Journal of Medicine. The IO toxicity occur in all the organs of our body. Actually, it affects almost all the organs. And we can...
دكتور أحمد افتح البرزنتيشن بس مش مفتوح.
كده فتحت؟
احنا شايفين السكرينة كلها.
ريسكنت بس شايفين البرزنتيشن بس مش مفتوحة.
كده تمام؟ Now you see the presentation?
No, not yet.
لا مش موجود.
طب you see my desktop?
لا.
هو كان موجود دلوقتي لا.
Okay.
تمام كده ايوه تمام
اوكي
تمام
okay. Actually, I start with this picture. We can say that the immunotherapy can affect any part of our body with the toxicity. It can affect the respiratory tract, the endocrine system, the kidney, the skin, the liver, the gastrointestinal tract. We can say that everything with itis can happen during the IO toxicity. The most common to occur is the skin and GI, definitely. We have a rare also toxicity can happen in the pancreas, pancreatitis, the uveitis, demyelination syndrome can occur also, autoimmune neuropathy, and rarely we can have some rare neuropathic disease like Guillain-Barré syndrome and myasthenia gravis. The organs with high lymphocyte reach are the organs that is affected more, like the skin and the gut. The frequency and severity of immune-related adverse events depending on the immune checkpoint inhibitor used and the regimen used, and also depending on the characteristics of the patients themselves. The toxicity actually occurred during the immunotherapy mimic the autoimmune disease, but they are not autoimmune disease. That's to say that immune checkpoint inhibitor-related colitis is not like inflammatory bowel disease. They are treated the same, but they are not the same. And the treatment of immune-related adverse events was extrapolated from the treatment of autoimmune disease, because we don't have any randomized trial of how to treat the immune-related adverse events. The treatment of immune checkpoint inhibitor related pneumonitis was extrapolated from the management of immune checkpoint inhibitor colitis. So we don't have a specific medication for immune checkpoint inhibitor pneumonitis. We have a typical kinetic of immune-mediated adverse event. Usually, the first to happen is the skin, followed by the GI, and followed by other organs like endocrinopathies, liver toxicities, and lately, which can happen very late in the course of the treatment, is the nephritis. As the immune-related side effects during the immunotherapy happen very fast with a specific pattern, we can see also the resolution of the toxicity have a specific pattern. Most of the toxicity resolves spontaneously within few weeks, except for the skin and the endocrinopathies, which may last for some time. Usually, the skin reaction occurs within 3 weeks of initiation of the treatment, followed by the colitis and GI symptoms, which occur after 3 to 4 weeks. Most of the patient, 85% of the patient, experience the immune-related adverse event within 16 weeks of initiation of the immune checkpoint inhibitor treatment, and they resolve within several weeks. We have the ESMO guidelines of treating the immune-related adverse events. As we said, most of the patients experience this within the first 3 months of treatment. Sometimes in extreme cases, high grade of toxicities, grade 3 and 4, biopsies from the organ may be needed to confirm the diagnosis of immune-related adverse event, and it is not another disease. Also, the patient selection during before initiation the treatment of immune checkpoint inhibitor should be taken cautiously. For example, if the patient is on has autoimmune disease and he is on immunomodulator or immunosuppressant. Also, some important points: if the patient developed immune-related adverse event and he will be exposed to immunosuppressant or corticosteroid treatment for more than 6 weeks, take care that the patient may have pneumocystitis. So we should give him prophylaxis against pneumocystitis during the therapy. This important statement came from the ESMO. They said that the clinical outcome of patients on immunotherapy is not affected by the use of immunosuppressive agents for the management of immune-related toxicities. So during the immune-related toxicities management, the survival and the efficacy of the immunotherapy will not be affected. We have a general guidelines of treating immune-related adverse events based on the grade of the toxicity. If we have a grade 1 toxicity, usually we don't use steroids. We continue monitoring the patient and we continue our treatment, but we put the patient on under careful monitoring. And if the patient shifted to grade 2 toxicity, usually we start with oral prednisolone with low dose, 0.5 to 1 milligram per kilogram daily. And rarely we use IV steroids, methylprednisolone at low dose also of 0.5 to 1 milligram per kg. And once the patient improved and the toxicity is grade 1 or less, we can restart again the immunotherapy and we start to taper the steroid over 4 to 6 weeks. But in grade 3 and 4 toxicities, usually we should stop the immunotherapy medication. And we usually, in grade 3, in most of the cases, it is difficult to restart, but in some instances, we can restart again the immunotherapy. We start usually with a higher dose of oral steroids, and if the patient is not improving within 2 to 3 days, we shift to IV steroids, or we can add alternative immunosuppressants. And once the patient improved, we taper again the steroids. For grade 4, usually we start with the high dose steroids, and if not responding, we run quickly to the IV steroids, and then we can add the other immunosuppressants. I will move now to organ by organ management of toxicity. The most common toxicity is a skin-related adverse event. Usually, the management of skin-related adverse event depends on the grade of the toxicity. For grade 1, we mean that we have a skin rash covering less than 10% of the body surface area. At this point, we should examine the patient carefully. exclude any other cause of this skin rash, including infection, allergy, viral infection, drug eruptions. And if you are sure that it is related to the immunotherapy, we should give the patient the instruction to use skin emulsions, avoid the skin irritation, avoid sun exposure. Sometimes we can use a mild strength of topical creams of steroids, and we can use oral histaminics, antihistaminics. For grade 2, this means that the rash started to cover more than 10%, but less than 30% of the body surface area. And at this point, we should take the opinion of our dear colleague dermatologists. Rarely, if the disease persists and the toxicity persists and is not resolved with the treatment, we may need skin biopsy at this stage. And the treatment usually based also on topical steroids, but with a moderate strength cream. And we should take the opinion of our dear dermatologist about which type of cream we can use. And we can use oral or topical antihistaminics also. For grade 3 toxicity, which means that the skin rash covered more than 30% of the body surface area, or we have grade 2 toxicity with generalized symptoms. At this point, a biopsy from the skin is mandatory, and we should take photos of the patient to follow up the patient. We start with topical steroids, and we start oral steroids, also prednisolone, at a dose of 0.5 to 1 milligram per kg. And after 3 days, we can start to taper the steroid dose if the patient is improving. If the patient is not responding, maybe we can use a higher dose of IV steroids, IV methylprednisolone of 0.5 to 1 milligram per kg. And once the patient responds and have a grade 1 or less toxicity, we can taper the steroids over 2 to 4 weeks. And for skin toxicity especially, until grade 3 toxicity, we can recommence again the immunotherapy after improving the toxicity. For grade 4 toxicities, which means that we have more than 30%, and we have other associated symptoms like purpura, like detachment, like skin discoloration. We should take a punch biopsy. We should have dermatology review, and we should start immediately IV steroids at a higher dose of 1 to 2 milligram per kg. And we should not again go back to the immunotherapy. The second part of our organs that can be affected is the endocrine system. Actually, we have a lot of endocrinopathies that can occur with immunotherapy. The most common is the thyroid gland, followed by the pituitary. We can have immune-related hyperthyroidism or hypothyroidism. Rarely we have hypophysitis, except especially when we are using CTLA-4 inhibitors. Rarely to have pancreatitis or adrenal insufficiencies. The symptoms are difficult. Usually it is a vague symptoms, and usually these symptoms and the endocrinopathies are long-lasting, and the patient needs a long time of hormonal replacement even after resolving of the acute phase. The pancreas and the adrenal gland are really to be affected. So this is a scheme of how to follow up our patient during the immunotherapy for suspected endocrinopathies. The most important is the thyroid gland, as we said, which is the most commonly affected. So we should monitor the TSH and T4 regularly during the therapy. The scheme said that we only have TSH normal and we have low T4. We should repeat again the TSH and T4 repeated with the next cycle. And if we still have persistent T4 low, so we should go and check the serum cortisol level at 9 a.m. because this is maybe indicating hypopituitarism. If we have normal TSH and elevated T4, so this is something strange and we should ask the endocrinologist. If we have elevated TSH and normal T4, this may indicate a hypothyroidism. So we should, if the patient is asymptomatic, usually we follow with the next cycle, and we never to consider thyroxine except if the TSH is highly elevated above 10. But if we have elevated TSH and low T4, this is a hypothyroidism. We repeat the next cycle, and if it is persistent, we should initiate thyroxine replacement. What about if we have a low TSH? If we have low TSH with high T4, this is give us susceptibility of having autoimmune thyrotoxicosis. So we repeat with the next cycle, and if the symptom persists and the patient is confirmed to have hyperthyroidism, we should start medical treatment with beta blockers. We can do uptake scan, we can do thyroid antibodies. And if we have low TSH and low T4, we should check the serum cortisol level at 9 a.m. because this may indicate hypopituitarism. So how to manage endocrinopathies in general? If we have vague symptoms like mild fatigue, anorexia, but there is no headache, or the patient is asymptomatic, we have only the defect in the lab, the laboratory defect in TSH or T4. So usually we take the pathway as we said in the previous slide, and we treat according to this. And if we have a hypopituitarism, which means that the TSH is low and the T4 is normal or low, we should check the serum cortisol level. If we have a 9 a.m. cortisol level of less than 250 nanomole per liter, or random cortisol level of less than 150 nanomole per liter, and we have vague symptoms, you should consider immediate replacement of oral hydrocortisone with a dose of 10 milligram daily. And if we have a normal thyroid function test, we continue to monitor the thyroid function. And if we have defect in the thyroid function, in addition to the adrenal function, we should consider replacing both of them. But usually keep in your mind that you should replace the cortisol first before replacing the thyroxine. If the patient has a moderate symptoms, like headache, but without any visual disturbance, or he has moody change, fatigue, but he is hemodynamically stable, this may indicate adrenal problem. So usually we continue to investigate the patient with MRI pituitary. We can check the adrenals, and we check the cortisol level at 9 a.m. and we check the thyroid function test. And we may consider giving the patient oral prednisolone at a dose of 0.5 to 1 milligram per kg. But this should be started after sending the lab, not to alter the lab results. And if the patient is not improving within 2 days, we should consider to start IV methylprednisolone. And we should stop the treatment with immunotherapy. If the patient has severe symptoms like severe headache, visual disturbance, hemodynamically became unstable, we should ask for our investigation, and we should start after taking the lab test for the pituitary axis profile. We should start IV methylprednisolone based on the blood test. What about the immune-related colitis? Immune-related colitis is the second most common side effect that can occur with the immunotherapy. Usually, we have a mild to moderate symptoms, rarely to have grade 3 and 4 colitis. We should know that colitis is not usually accompanied by diarrhea. So colitis is completely different than diarrhea. So there is no significant association between diarrhea grade and the colitis grade. There is no association between colitis grade, diarrhea grade, and the presence of histologic inflammation. Usually the patient in the grade 1, he has symptom, usually can be treated by symptomatic treatment, fluid electrolyte supplementation, and he can continue his treatment. But if the patient has grade 2 or higher toxicities, the immunotherapy should be stopped. If grade 2, we start with oral steroids at 0.5 to 1 milligram per kg, and we should rule out any infection. If he has grade 3 or 4, which is considered severe colitis, we should discontinue immuno checkpoint inhibitors completely, and we start IV steroids at 1 to 2 milligram per kg. And we should, in high risk criteria, we should start immediately immunosuppressant. And the immunosuppressant should be started within the first 10 days of symptoms, because we have a data say that starting the immunosuppressants like infliximab or vedolizumab in the first 10 days of symptoms improved a lot the response. I searched a lot for the names, the trade names for these medications, because we are, as an oncologist, never used this medication before. And we can say that infliximab is named Remicade, and vedolizumab is Intivo. This is a picture of colonoscopy during immune-related colitis. We have what's called the severity or high-risk criteria. If you find this in the colonoscopy on the picture on the right side, in picture B, D, and F, you should consider this as a severe case. The severity is based on we have large ulcer of more than 1 centimeter, or the depth of the ulceration is more than 2 millimeter, or we have diffuse or patchy erythema, or we have extensive colitis beyond the left colon, or we have multiple superficial erosions. Another lab test, which I think it is available in Egypt, is to measure the stool calprotectin. If we have the stool calprotectin more than 450, this is considered as severe colitis, and you should start steroids, and you should start immunosuppressant within 10 days if the patient is not improving. We have this trial published in the journal Immunotherapy, published in the Journal of Immunotherapy Cancer in 2019, of the early introduction of immunosuppression, infliximab and vedolizumab within 10 days. And they found that the early introduction of this medication within the first 10 days, we have a favorable impact on the disease, better response to therapy, reduced length of hospital stay, lower immunotherapy colitis recurrence rate, and we found that the vedolizumab is more effective than the infliximab to improve the recurrence. If the patient failed on infliximab, we can use the vedolizumab, but the vedolizumab efficacy at this will be 67% compared to 95% if used as a first line. And if we have a patient with vedolizumab refractory colitis, we can use tacrolimus, and I searched for the trade name, it's called Barograph. And I think we should check with our gastroenterologist colleagues about the doses of how to use this medication. We have rare other immune-related adverse events like hepatitis, and usually we follow the same scheme. If we have grade 1, which means that we have liver enzymes of higher than normal upper limit, but less than 3-fold. So we continue the treatment of immunomedication, but we should repeat the liver enzymes regularly every week. If we are still in the grade 1, we continue the treatment. And if we shift it to grade 2, which means that 3 to 5-fold elevation of the liver enzyme, we should stop the immunotherapy. And we start with oral steroids at oral prednisolone 1 milligram per kg. And we check regularly the liver function. We complete the liver function with bilirubin, albumin, and we check viral markers to just rule out concurrent infection, hepatitis A, B, C. And we should also ask the patient about the concurrent medication like statin, like antibiotic, like alcohol, to give him advice which medication should be stopped. If the patient has a higher grade, grade 3, which means liver enzymes from 5 to 20 folds, we divide these patients into 2 groups. If we have the liver enzymes less than 400 and normal bilirubin, we start with oral steroids. But if we have liver enzymes more than 400 or other disturbed liver function like INR elevated, low albumin, high bilirubin, we should start IV methylprednisolone at a dose of 2 milligram per kg. If we have grade 4, the immunotherapy is never to be reconsidered again. Grade 4 means that we have liver enzymes more than 20 folds, and at this, the patient should be hospitalized, and we start IV methylprednisolone at a dose of 2 milligram per kg. What about immune-related pneumonitis? Actually, this picture mimics what we see nowadays in the COVID-19 era. It is immune-mediated pneumonitis, typically like the COVID. We can organizing pneumonia, we can hypersensitivity pneumonitis, we can see non-specific interstitial pneumonia, we can see non-specific pattern. Actually, the incidence to have immune checkpoint related pneumonitis is not that much high. We have less than 2% with Nivo, less than 4% with Bembo, and less than 1% with PD-L1 inhibitors, Atezo. Usually the incidence with PD-1, PD-L1 inhibitor is higher than that we have with CTLA-4. Usually we have a concurrent other immune-related adverse event like skin rash in 20% of cases, colitis in 14%, and endocrinopathies in 7% of patients. The management usually based on the severity, and after ruling out other causes of these pneumonitis. Sometimes we have bacterial infection actually, and it was misdiagnosed as immune-related toxicity. So we should rule out the infection. We should rule out pulmonary edema, pulmonary embolism, congestive heart failure, other diseases like sarcoidosis, pericarditis, myocarditis. Sometimes the patient has severe dyspnea, and then the lung is completely free. He maybe have myositis, or may have, and this myositis affects the diaphragm, or maybe a rare myasthenia gravis or Guillain-Barré. And then we should categorize the patient if he is a mild symptoms or severe symptoms. If the patient, we found only mild symptoms or asymptomatic, and there is no need for oxygen supply, and we find only changes in the CT, usually the patient need only to be followed up. But once we have a grade 2 or higher toxicities and the patient doesn't need oxygen therapy, we can treat the patient at home, but we should stop the immune checkpoint inhibitor treatment, and we should rule out infection, and we should start a steroids, oral steroid dose at low dose of 1 milligram per kg. If we have a higher toxicity, grade 3 or 4, we should stop the immune checkpoint inhibitors. We start antibiotic empirically. Even if we excluded infection, we should start antibiotic empirically, and we should give prophylaxis against pneumocystitis. And we should start IV steroids in the form of methylprednisolone at 1 to 2 milligram per kg. And if the patient is not improving within 2 days, we should start cyclophosphamide or infliximab or MMF. MMF is known as Cellcept also. What about cardiovascular system? It can be affected with immune checkpoint inhibitors. Yes, we have immune checkpoint cardiovascular toxicity in the form of arrhythmias. We can see arrhythmias, we can see myocarditis, we can see pericarditis, and also we can see vascular problem in the coronary artery disease. We can have temporal arthritis and persistent headache. We can have cerebral vasculitis. We can have hypertension. All these are immune mediated. And usually with the same scheme, if we have mild grades of toxicity, we monitor the heart with ECG, echo, cardiac enzymes, and we stop. When we are dealing with the heart, there is no jokes. We cannot continue the medication. Stop the medication immediately, even if you have a mild grade 1 toxicity. And if we have grade 2 or higher, usually we permanently discontinue the immune checkpoint inhibitors. For grade 2 and 3, we start with oral steroids, and if the patient not improving, or grade 3, we start immediately with IV steroids with continuous monitoring of the cardiac function. And once the patient improves, we can taper the steroids over 4 to 6 weeks. If we have severe cases, the patient should be admitted to hospital, methylprednisolone with high dose given for 1 gram per day for 3 to 5 days, and then we shift to lower doses in the after days. And once the patient improves, we can taper the steroids over to 4 to 6 weeks. And if the patient is not improving on steroids within 24 hours, we should add immunomodulator like tocilizumab, like infliximab, like alemtuzumab, like MMF, as we said. Other rare toxicities that can happen with immune checkpoint inhibitor is neurological problems like encephalitis, aseptic meningitis, acute immune demyelination, myasthenia gravis, myositis, cranial nerve affection, cranial nerve neuropathies. But thanks God, the percentage of these things to happen is less than 0.2%. And the scheme is the same. We start with oral steroids if we have mild toxicity grade 1 or 2, and if the patient is not improving or has a higher grades of grade 3 to 4, we should shift to IV steroids. And if the patient having a symptoms like Guillain-Barré or myasthenia gravis, I think immune IV, IG can be considered plasmapheresis can be considered, and usually this is a serious and critical problems and should be monitored and treated at the hospital, even in the mild grades. And the ESMO guidelines said that the neurological problems usually start from 6 to 13 weeks. Usually we can find these symptoms, but we should exclude that it is not related to disease progression, development of brain metastasis or infection or metabolic disturbance. And if we exclude all other factors, we should start the management early. All the patients should withhold the treatment. Grade 1 only can restart again, but in very mild cases. Oral steroids should be started in moderate symptoms. High dose oral or IV steroids should be considered. Plasmapheresis or IVIG may be required to treat myasthenia gravis or Guillain-Barré syndrome. Nephritis, another rare toxicity that can happen with immune-related medication. And usually we follow the same scheme. For grade 1, we do further investigation to exclude infection, to exclude other problems. And for grade 2 or higher, renal biopsy may be needed. Usually we stop the immunotherapy. The patient need hospitalization. If not improving shortly within 2 to 3 days, we should shift to IV steroids. And if we have a higher grades, we permanently discontinue the immunocheckpoint inhibitors. And the patient, most of the patient recover, but take some time. So our take-home message, usually we have toxicities with immune therapy. I think more than 30-35% of patients develop toxicity. But alhamdulillah, thanks God, they are grade 1 or 2. If we have grade 3 or 4 toxicity, usually immune checkpoint inhibitor should be discontinued. Most of the toxicities occurs within the first 3 months of therapy. Don't forget, if the patient has myositis, you should also rule out myocarditis with cardiac enzyme. If the patient has myocarditis and ptosis, PET CT scan should be done to rule out orbital ptosis. If ptosis occur, we should rule out orbital myositis and myasthenia gravis. If persistent high-grade fever, we should rule out infection, fibrinolysis syndrome, cytokine syndrome. And in severe colitis, stool calprotectin more than 450 or severe endoscopic features, start with immediate infliximab or vedolizumab within 10 days. And if you are going to take steroids for more than 4 weeks, don't forget to give prophylaxis against pneumocystitis and give vitamin D and vitamin C supplementation. By this, I end my talk, and I would like to remind you about our next event, inshallah, on the 8th of April, about prostate cancer. And this is a program. And you can check all our lectures of this meeting and all our previous meetings on our YouTube channel, the East Mediterranean Oncology Group on YouTube. And thank you. Thank you all the attendees, and I hope I didn't take too much time. And lastly, I'd like to present my dear colleague, Dr. Ahmed Ali. Dr. Ahmed Ali will present real cases from our life with the management of immune checkpoint inhibitor. Dr. Ahmed Ali is a consultant clinical oncology at Zagazig University and International Medical Center. Dr. Ahmed, please. Dr. Ahmed, unmute the mic, please.
This is the presentation is you see my screen?
تمام دكتور أحمد اتفضل.
Okay. Thank you, Dr. Ahmed Gaballa, for your kind introduction. I hope that there is still some audience online now in front of you after this long day of information. And I need to tell him that you should go to sleep after this event, not to be depressed from this large amount of knowledge and science, but don't, especially young oncologists, please don't be hurried to be expert. This you will take time and effort from you to understand and collect this amount of knowledge and science. My case today is about metastatic.
Dr. Ahmed Ali, just I want to tell you that we have 100 attendees till now.
Okay. Okay. I hope this can be interesting for him, and hoping them to get a more experience in immunotherapy after these presentations and your effort in this meeting. My case about metastatic urothelial carcinoma case scenario. My case is male patient, 50 years old, hypertensive. His complaint was gross hematuria, painless hematuria for 2 months, diagnosed as high-grade urothelial carcinoma. Radical cystectomy was done with ileal conduit, post-operative histopathology T3 and 0 at December 2019. Received 4 cycles as adjuvant therapy, gem carboplatin, in last May. Then he presented to the hospital with fever and diarrhea and diagnosed as E. coli sepsis. After 1 month of treatment, he recovered and presented to us complaining of generalized weakness, fever again. PET scan for this patient showed bilateral, as you see, bilateral pulmonary metastasis, cervical and supraclavicular lymph nodes, pelvic tumor bed mass, omental and peritoneal deposits, abdominal lymph nodes. Regarding the performance status is 1, hemoglobin level 10.5, serum creatinine clearance about 45. And first step in my practice to do for this case, I have easy biopsy for supraclavicular lymph node. The biopsy from supraclavicular lymph node confirmed metastatic urothelial carcinoma. Second step in my practice, also I asked for the PD-L1 because this patient usually in our practice defined as chemorefractory because treatment-free interval after adjuvant chemotherapy is only 2 months. And the patient received nivolumab because he is chemorefractory, considered second line, and also PD-L1 is positive. Received nivolumab 240 milligram every 2 weeks started August 2020. And this is a PET-CT at presentation, as you see, diffuse metastasis. Post 8 cycles, about 4 months of therapy, the patient achieved near complete response in November 2020. And the decision at this point was to continue nivolumab to complete 16 doses. And the last PET-CT this month showed near complete response. This is the baseline PET-CT, and this is the after 16 cycle of nivolumab till this month. I don't need to be more. I need more discussion for this case, but I know this is the time too late. If there is any discussion point for this case, I will wait with Dr. Ahmed Gaballa and faculty.
Thank you, Dr. Ahmed, for this nice case. I have one question only. You think it was mandatory to have the PD-L1 before starting the nivo for this patient, or if the patient is even non-expressor for PD-L1, you will start the same treatment?
I think this patient is, by definition, is cisplatin ineligible and also chemorefractory because the treatment-free interval was only 2 months after the end of the adjuvant chemo, which is the inclusion criteria for the nivolumab study.
I think without testing the PD-L1.
Yes, yes.
Yeah. If the audience want to ask Dr. Ahmed about this nice case, please, we are waiting for your questions. I will
to discuss with the faculty, Dr. Ahmed Hassan, Dr. May, Dr. Ahmed Gaballa, about what about this marvelous response. We usually facing some patient give this marvelous response with multiple indication for immunotherapy like lung, like HSC, but some cases didn't achieve any benefit after immunotherapy. I think we still have need further biomarkers or predictive biomarkers for this marvelous response.
Yes, Dr. Ahmed Hassan, you can answer this, please.
Dear Dr. Ahmed, it's a pleasure to see you. Yes, definitely we need some biomarkers to tell us. I was just demonstrating in the small cell lung cancer talk that if you look at the median progression-free survival, you'll find that there is no difference at 5 months between the groups, while for some patients who have responded, they have long-term responses for up to 2 years with significant improvement of survival. And that is why if you put all of them together in one basket, you will see the overall survival benefit. But we still don't have a tool, whether in small cell lung cancer or many other tumor settings, to tell which patients are those good responders. Well, we can use the PD-L1 cutoff values in some tumor settings, like breast cancer. We had our guest speaker from Saudi Arabia earlier today showing us that the cutoff value for breast cancer, for example, was 10%. So we know in some tumor settings, you have to look at the PD-L1 overexpression. But this does not apply in other tumor settings, like in hepatocellular carcinoma, renal cell carcinoma, small cell cancer. And indeed, we need some other indicators to tell us which patients you should consider immunotherapy and which patient not, and which patient you can consider subsequent immunotherapy, for example, if they failed first line or not.
Yes. So for that reason, Dr. Ahmed, I in my clinical practice, I have long experience with immunotherapy. Usually, I don't have a strict predictive biomarker. So I usually, if I have a bulky tumor, especially the primary bulky tumor, I first proceed for hypofractionated radiation therapy to the bulky tumor in order to change the tumor to a hot tumor and stimulate the immune system. So I give another biomarker, in my opinion, by radiation therapy.
Yeah, but we can keep it in the context of clinical trial. We cannot tell our guests that this is a generalized information. Dr. Ahmed Hassan.
I was about to say the same as Dr. Gaballa said. It's theoretically, it looks appealing. And we know that radiotherapy can induce responses to immune therapy. However, any clinical trials to confirm this notion.
And also the same theory, the same concept is used when we are using the IO. If the tumor microenvironment is not suitable for working of the PD-L1 inhibitors, you can give the CTLA-4 to work on the systemic circulation instead of working in the tumor microenvironment. But all these theories are not implemented. Yes, we don't have data to confirm these theories.
Also, the IO combo with the chemotherapy may have this theory as well. As we see in the trials, then the IO combos with chemotherapy, the shoulder of pseudoprogression mostly disappear.
Yes. Okay.
Yes.
Congratulations, Dr. Ahmed. It's a very nice case. But I just wanted to ask you, why did you pick Nivo? It's not a wrong choice, but just out of interest.
Yes, because I have long experience for urothelial carcinoma at that time for Nivo more than because it's the first PD-1 inhibitor present in Egypt, and we have more experience at the time of this case. Not only, but in the second line we have multiple options for PD-1 or PD-L1 inhibitor.
And also I think we have data from FDA that Genentech in USA voluntarily withdrawn the Tecentriq from the platinum from prior platinum treated the metastatic urothelial carcinoma. So I think now we have only Bembo and Nivo. At ESO, Genentech removed this indication just I think a couple of weeks ago.
Yes, we have so many
options, I guess sometimes it's confusing which one to pick, which one would be the best for the patient.
Yes,
Yeah.
yes.
That's why
We have overlapping, yes.
Yeah.
I think by this, we should not be more late for our attendees, our dear guests. Thanks all of the faculty for this nice meeting and nice presentations. And I'd like to thank also the sponsor, BMS, for day one of the meeting. I'd like to ask to thank Mr. Sameh and the Worldwide Academy for organizing the meeting, Smart Vision for the IT support, and the nice presentation you are seeing all the attendees on the screens. Please follow us on the YouTube channel to check all our lectures, presentations, all our meetings, previous meetings, and this meeting also. And inshallah, we hope to see you all on the 8th of April for our next meeting about prostate cancer. The chairman of this meeting is Dr. Ahmed Ali. Dr. Ahmed, if you want to tell us over in 1 minute a hint about the next meeting. And by this, I close this meeting. Dr. Ahmed, you can start.
Inshallah, we have a great faculty for this meeting about all updates about prostate cancer. Will be in 8th of April at 6 o'clock p.m. We have at this meeting a great faculty. We have Professor Amil Bah from England. We have Professor Muhammad Abdullah, Muhammad Farouk, Muhammad Yassin, well-known figures in prostate cancer presentations. So I hope you are all present and get a benefit from this meeting, and we will continue for further meeting, inshallah.
Thank you, Dr. Ahmed. And by this, I would like to say good night and good evening for all the people, all the attendees, my dear professors, colleagues, and I hope to see you again in person soon, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you. Assalamu alaikum.
Thank you.
Thank you all.